you can see at every time you are having risk factors with a symptom or a sign. And as I've said earlier, risk factors alone usually form a yellow flag. But when you have risk factors and then you have few signs or symptoms, that usually forms a red flag. So when you have family history of unexplained sudden death, so usually this is like saying a family history of a heart disease. So whenever you have a family history, so if the patient does not report that their relative, either father, mother, child, any primary relative, has had heart disease and they died from it, it's not every patient that would have been diagnosed. Some is just a sudden death, but it is thought to come from a cardiovascular source. So if there is an unexplained sudden death history in the family, and then the patient has palpitations, and that palpitations is more than 6 per minute. So you have the palpitations greater than 6 palpitations per minute, and it lasts for hours. So the patient is having more than 6 per minute, and it lasts for hours, and they have pain in the chest, shortness of breath, fainting, or lightheadedness. These things put together with a family history of an unexplained sudden death forms a red flag. This needs to be referred. So family history will be under family history. The palpitations will be under examination. Pain will be under history. A shortness of breath can be under history also. Then fainting, that also under history, and lightheadedness. So you can see that many of these from history, at least one from examination, and you have a family history. So it's a comprehensive assessment. And as you take this information, you are just recording. It is at the end of it all that you sit down and you look at what you have recorded. You say, okay, is there family history of unexplained sudden death? Yes, I can see that. Does the patient has palpitations more than 6 per minute? Yes, I've seen that. Is there pain? Yes. Shortness of breath? Yes. Fainting? Yes. Like, okay, this put together, my evaluation or interpretation is that it is a red flag for cardiovascular disease. What is the decision? Quickly refer the patient. Feeling moderately/severely winded, climbing single flight of stairs. So you climb single flight of stairs, you don't get winded, you don't lose your breath. But when you feel moderately and severely out of breath while climbing just a single flight of stairs, that on its own is a red flag. So you can see this is a symptom, not a risk factor. So you hardly find 1 or 2 risk factors forming a red flag. But a symptom, even 1 or 2, can lead into a situation of an emergency of a red flag, and it requires referral. Fainting without lightheadedness. Usually, if you have a neurological condition, because we discussed this under neurological system, that you'll have lightheadedness, dizziness, or nausea, and then the patient faints. But under cardiovascular disease, especially when you have heart valve or arrhythmias, the patient faints without feeling any lightheadedness, dizziness, or nausea. So it's just suddenly, patient just faints. Maybe when the patient regains consciousness, and in the history you ask, when you fainted, before you fainted, did you feel lightheaded? Was there any dizziness? Did you feel any nausea? I say, no, I didn't feel any of those things. I just fainted. So this is more related to cardiovascular than neurological. When the upper back is cool or sweaty, so the patient feels sweating just at the upper back in a known CVD. Okay, so there's a past medical history. And there is a difference of 40 millimeter mercury in pulse pressure. So you have the systolic and the diastolic, you take the difference and you have something that is greater than 40 millimeter mercury. Sorry, Hafiz, if you are there, just take over. So you have the difference of 40 millimeter mercury. The patient reports having sweat, but focused more around the upper back. So this is a case of emergencies. It should be referred. When you have intermittent claudication, just like I mentioned earlier in the earlier slides, so the patient is having pain in the limb when moving, walking around. Usually it reduces with rest. So in the other one, it was a red flag because even when the patient is resting, the pain does not go down. But this one, there is pain with activity. When the patient rests, the pain reduces. There's also nocturnal aching of the foot. So in the night, so patient does not have pain in the foot, but in the night, the patient feels aching in the foot. There's also ischemic wrist pain. So you have the pain while you are resting. Okay, so similar to the other case. And you now have skin changes, either bruises in the skin without unexplained. So usually when you fall, when you scratch the skin, things like that, you are going to have bruises. But just like that, you begin to see bruises in the skin, meaning blood is not getting to the skin as much as it needs to. So you have those skin changes. So that's suspect vascular occlusive disease. So if you look at all these evaluations, all these symptoms, signs, and risk factors, they are leading towards suspicion of an organic pathology. Because when you have vascular occlusive disease, you have the vessels being occluded. This is an organic pathology, and this is something that needs referral. Now, what are the yellow flags? The yellow flags are past or family history of heart disease. So this is what I keep telling us, that all this will depend on two things. We even know what risk factors, symptoms, and signs to assess in patients. We know how to assess them in patients. And then we'll now come and do this evaluation. After we have assessed across the Clarkin process, we now come and do this. So past or family history of heart disease. Either the patient has had heart disease in the past, or a family has had heart disease. If the patient is more than 65 years, so the moment your patient is 65 years and above, and the patient is black, of course, we're in Africa, so most of our patients are going to come, they are black. So it's black, more than 65 years, and you ask, have you had any heart disease? You say, yes, I've had heart disease in the past. Okay. Or no, I've not had any heart disease. Has any member of your family had heart disease? Yes. Then this is a yellow flag. What it shows is that, and you can see all these are risk factors, not a single sign or symptom. And that is why it is a yellow flag, because risk factors put together don't form a red flag, hardly form a red flag. So this yellow flag, what do? You continue to monitor the patient. Is there any intermittent claudication that does not get relieved by rest? All those other things that we mentioned in the red flags, if they are there, now in addition to what we have here as a yellow flag, and that is when you refer. But just having this past medical history or family history of heart disease, age 65, is black, why should you really think that this patient has or may have a heart disease that you want to refer them? You can't change being black. You can't change the age. Say, okay, you should go back and be 40 years. You can't change that. And you can't change the fact that they have had a past history of heart disease. But what you can do is that, what are the risk factors of having a heart disease? Is the patient a smoker? Is he living a sedentary lifestyle? Does he take alcohol? What is the type of food that they eat? What level of cholesterol it has? And all these things, you now look at them, you advise them to change their lifestyle, especially what is within the scope of your practice, the issue of sedentary lifestyle and other things. If there are other things that they require, for example, the attention of a nutritionist or dietetics. You refer them so that they get prescriptions of what food they should eat. All this to help minimize that risk of having another heart disease if they are the ones that had the past history. Or if it is the family history, only no past history, then for them to be able to avoid having it. But at the point that they now begin to have those other symptoms added to it, that angina pain, the myocardial infarction pain, the intermittent claudication pain, especially those that said they are not relieved by rest or by changing position and things like that, then that's when you now have a case to refer the patient. Intercostal muscle or periosteal trauma. Please, just a second. I think the car that I came with has a problem with security, something. I need to just put it off. Sorry, just a few minutes, please. Yes, apology. The car has security that after a few minutes, it just sets itself off. So I had to go and remove the battery head. Sorry. Yes, so I'm back. Yes, so we have intercostal muscle or periosteal trauma. So whenever there is an accident and it affects the chest muscles and bones, so when there is chest pain with vigorous coughing, so there's a report of accident that has affected the chest, and the patient now reports chest pain with vigorous coughing. So there is need to further assess the patient to see if there are other risk factor symptoms. Well, not really risk factors, because with an accident, you're looking more of symptoms and signs. So when there is recent history of pericarditis, so you can see our past medical history should be really very comprehensive. I mean, just asking one or two conditions and that's it may not really reveal many of the things that will help us with the evaluation. So very important for it to be more comprehensive than what we usually have. Another thing is that leaving it just to the patient to say, have you had any past history of any disease? Sometimes may not help. As I've said, patients may not reveal some issues. One, because they think it's not within their scope of practice. And therefore, why should I really reveal it to you? Let me reveal it to the physician. Another thing is possibly if they are embarrassed or if they are afraid, just like we discussed during last week's lectures. So when they have the history of pericarditis, sometimes they won't tell you it's pericarditis that they have had history with. But if they say, I've had a disease, it affected my heart, and they are now giving you the symptoms, it's up to you now to be looking at those symptoms to say, okay, what disease does this explain? Which of diseases do I think? So what are the risk factors, symptoms, and signs of pericarditis? So that as they are stating those, you are now trying to imagine what condition it is that they have had. So it's really not a straightforward thing sometimes, doing all these evaluations, because you have a lot of information that is missed. You can't go back and do a diagnosis of pericarditis because it's not within your scope of practice to do diagnosis of pericarditis. I mean, it's not an easy thing, but at least gather as much information as you can. So when they have chest pain, neck pain, left shoulder pain, now we'll come to see the pattern of referral from the cardiovascular system. And these are some of the areas that pain is referred to. So when you have pain in those areas and you have recent history of pericarditis, so this is musculoskeletal pain that you think is musculoskeletal pain. It is in the musculoskeletal areas. It's in the neck, it's in the shoulder, it's in the chest. So not really angina or myocardial infarction pain, but this is pain that seems like it is coming from the musculoskeletal system, but could have been referred from the cardiovascular system. And the patient also reports dyspnea, difficulty breathing, the pulse rate has increased, the blood pressure has increased. All this put together to me would have looked like a red flag. But from this evaluation, it's a yellow flag. So meaning there are still some things that need to come in to make it a red flag. Sudden onset of pain with activity. So the moment the patient begins activity, they just begin to feel pain. They have shoulder and neck pain. These are areas of referral from cardiovascular disease. So you have that sudden onset of pain with activity, and then there's shoulder pain or neck pain. This could be thoracic outlet syndrome. So you know, between the neck and the thorax, there is a place where the nerves, vessels, what artery, veins pass through. So if there is any pressure there that stops those structures from functioning, you are going to have a syndrome that has symptoms from the nerve and from the vessels. That's thoracic outlet syndrome. So it's an organic pathology, and therefore when you have sudden onset of pain with activity, and then you have shoulder and neck pain, then begin to suspect it, and then you need to have more symptoms or signs for you to be able to know if there is need for referral. When there's history of coronary artery disease or myocardial infarction, so there's history of it. So in the medical history, past medical history, a patient has reported having this, and then now they are reporting with chest pain, shoulder pain, neck pain, or TMJ, temporomandibular joint pain. So when they have pain around those areas and there was a history of CAD or MI, and then it's a yellow flag. Pain in upper part of the body. So when you are biking or you are climbing stairs, it is the lower limbs that are working. So why is it that I'm now having pain in the chest, in the thorax, upper part of the body. Why should that be? So that is a sign that there is a problem around or in the heart. So pain in upper part of the body after activity involving lower part of the body, that's a yellow flag. When there are risk factors of coronary heart disease or history of angina. So can you see how important these risk factors are? And also there is shortness of breath while walking with arms extended overhead. So possibly you reach up, you want to nail a hammer, put in a nail in the wall, and you feel pain. But when you are now using the hands, no matter how rigorous it is, but it is the hands are not over the head, you don't feel that same pain. So there is ischemia. But very important, the shortness of breath while working with the arms extended, it's shortness of breath, not pain. So when you feel short of breath while working with the arms extended over the head. But at the same time, there is also risk factors of coronary heart disease or a history of angina. So let's get this clear. You look for the risk factors of coronary heart disease. And then if the patient reports history of angina. So for the history of angina, it means there was angina already. But the risk factors of CHD, it's not that there was a CHD, but there are risk factors of the CHD. So you go back and look at them. Is it smoking? Is it sedentary lifestyle? Cholesterol? What other things? If the patient has reported them, or if they have reported that they have had angina, and then now they are reaching up to nail something or to manipulate something, and they now begin to have shortness of breath. So suspect ischemia. That is a yellow flag also. You need more investigations to be able to know whether you need to refer. So arrhythmias in SCI, spinal cord injured, cardiovascular accidents, or traumatic brain injury patients. So when you have the arrhythmias in any of those patients and they have dizziness and their pulse increases, so all this, so they have had those, but there could be another current situation, current issue with the cardiovascular system. So that is a yellow flag. Throbbing pain. It's important to understand the different types of pain. They will say throbbing, shooting, and a number of them, because these evaluations will depend on what type of pain that the person has. So if a patient has a throbbing pain at base of the neck, back, interscapular areas, so around that neck, back, interscapular areas, and it increases with exertion, that also is a yellow flag. So these are some of the areas. If you remember from all the text, we kept referring to the shoulder, trapezius, the neck, the jawline, that's the temporomandibular joint, the chest, and also medial part of the arm and forearm. So they are similar to what we saw in pulmonary. We looked at pulmonary last week. The presentation is similar to what we there was no temporomandibular, but now we are seeing temporomandibular. But the neck is there, the trapezius muscle is there, the shoulder is there, and around the chest is there. So from the back, this is where you see the pain from the neck to the trapezius muscle to the shoulder, but also down to the interscapular area and the upper back. So these are all areas that a cardiovascular system can refer pain to. These are other presentations. So it's not always that the patient will present with pain in all those areas. In as much as they present with pain in any of these isolated areas, then you can still suspect a cardiovascular origin, especially the heart. So you can see them. This is under the breastbone, in the larger area of the mid-chest. The temporomandibular joint is there, the neck is there, and then you have mid-chest. And this one, you have the mid-chest, the shoulder, the trapezius, but you also have the medial side of the arm and forearm. while in this one is towards the abdomen, so the upper part of the abdomen. So usually you might mistake this for indigestion. We are going to look at GIT. Possibly it might even be the next system that we'll look at. So in GIT, you have, because the GIT has many parts, there are some parts that send, especially the stomach or duodenum, that sends pain to around this area. So it's important to be able now to ask other questions that will help you to differentiate between pain referred from the cardiovascular system and pain referred from the GIT. Very important. These are other areas, especially here from the back. This can be isolated areas. You can have just the shoulder and the medial side of the arm and forearm. You can have only the temporomandibular and the neck, or you can have the temporomandibular, the neck, and the chest. So always consider thinking of the cardiovascular system when patients present with pain in any of these areas that we have looked at. Yes, gastrointestinal. Now, let me take time to, I think this is what we were supposed to do last week that we were not able to do. I believe Dr. Zubair would have given much more information than what I've given, but unfortunately he can't be here with us. Let me emphasize very strongly what I've said earlier, that we really, really need to be able to understand the risk factors, symptoms, and signs as a knowledge first. And then we will now be able to have the skills to identify those risk factors, symptoms, and signs of diseases in patients. And then we'll now come to this evaluation. That is what will help us to make a decision as to whether to refer the patient or not, or whether to continue to monitor them to know if there is need for referral. So I did a search from the books that I have on my system, and I realized that I have books that present all these three. So there are books that show what the risk factors, symptoms, and signs of diseases in these systems are. I've also got at least one or two that show what do you even do? How do you assess? If it is history, what questions do you ask to be able to identify risk factors, symptoms of those diseases as listed in those other books? And then I also got books that are now doing the evaluation. And with the evaluation, it's much more comprehensive because they give clinical scenarios. They give clinical scenarios. So this is a patient that has this, and because of that, we make a decision that he has this. So what I'm going to do now, I've already shared this document, the textbooks. When I came in at 9, you will see that I spent about 3 minutes before I started speaking. I was trying to upload them because they were heavy, they were not uploading, but I just realized now that all of them have uploaded on that Ray April 20th workshop. So you can study them. I'm going to share one of them that shows what questions you ask to be able to identify, because in these slides, all we are saying is that if there is shortness of breath, if there is difficulty breathing with this activity, if there is this, if there is that, but how exactly do you approach the patient? What questions do you ask them? What do they say to you? And how do you record them? How do you now use that information in the interpretation? These books have this information is there in those documents. So let me just quickly share that just to let you know how you can use it. But most of these things are things that you're going to do at your own time. Yes. So this book, you'll find it on that WhatsApp group. It's called Clinical Examination, a Systematic Guide to Physical Diagnosis. And the good thing about this book, I've not gone through the whole of it, but from the title, the Systematic Guide to Physical Diagnosis. So can you see what we have been looking for? How do we make a physical diagnosis? So this is showing you how do you do the clinical examination that at the end, it helps you to go to a clinical diagnosis. But what is relevant for us because of this workshop is the systems review. So sorry, yesterday, okay, those that were here yesterday, someone asked me a question about the difference between systems review and review of system. And I think I defined them, but switched them. So I hope those that were here yesterday have joined, I can still, maybe I will explain this at a later stage when those ones that ask the questions are here. But before then, when you do systems review, you are looking at each of the systems. So you are reviewing each of the systems. But at some point, you are going to have a focus on a particular system that you want to expand and get more information, and you focus on that system. That is when you now do a review of systems. So you are reviewing that system. But systems review is all the systems, you are reviewing them. You are asking questions about this system, you are asking questions about this system, you are asking questions about this system to be able to see which of them you suspect has a problem for the purpose of referral. But then when you are reviewing a system, you focus on that system and you review it. So I hope those that were there yesterday, especially the person that asked me the question, I can say I make a mistake in refining them as switching the two. So inquire about common symptoms and 3 or 4 of the common disorders in each major system listed below. Not all these questions should be asked of every patient. So that is another thing. Usually you have some risk factors at the earlier level that helps you to really suspect if there are problems in the systems. I don't know if that's what they are referring to or something else, but let me just go straight to the systems. So cardiovascular system, this is the one that we just finished looking at. Have you had any pain or pressure in your chest, neck, or arm? So can you see the question now? It's purposeful. It's directed directly to find out an information that will be helpful to you. We kept talking about myocardial infarction earlier. I will have this question coming. They are suspecting that this patient has myocardial ischemia. Are you short of breath on exertion? So of course, for our people here, use the words that will best get to them as what you mean. What do you mean by exertion? Is it everyone that will understand that? Use the right wordings. So how much exertion is necessary? Remember when we were discussing the issue of angina pain, that we said the increase in intensity, but also with threshold. And those other things. So this is the information that you want to get. So you don't go and begin to ask the patients, does it increase? Does the intensity increase? Does the threshold increase? They wouldn't understand all those things. So these are questions that are really more they get to the patient and they understand them more. Are you short of breath on exertion? How much exertion is necessary for you to be short of breath? Have you ever woken up at night short of breath? So cardiac failure, thinking of cardiac failure. Can you lie flat without feeling breathless? Have you had swelling of your ankles? Have you noticed your heart racing or beating irregularly? I think we were looking at arrhythmias there. So you can't just ask the patient, do you have arrhythmias? No. We also looked at palpitations. These are things that you assess anyway, but arrhythmias, the abnormal breathing pattern. I can ask the patient in this way, and you'll be able to know if there is arrhythmias or not. Have you had blackouts without warning? So now, this is that question that we're talking about, because you can't be asking the patient whether they had lightheadedness, nausea, and all those things. They don't know those terminologies. And to make it very simple, blackouts without warning. So that warning are those things. You can explain the warnings. To feel like you want to vomit, to feel your head is light, I mean, there are signs. People know that they feel some signs, or they are warned that they are going to faint. That is why sometimes when the person is standing, they quickly say, get me a chair, or they just begin to look for something to sit. They know the signs. So have you had blackouts without warning? Have you felt dizzy or blacked out when exercising? Severe aortic stenosis or hypertrophic cardiomyopathy? Do you have pain in your legs on exercise? Do you have cold or blue hands or feet? Have you ever had rheumatic fever, a heart attack, or high blood pressure? All these things are questions that you can ask patients directly. But as I've said, these books are from other parts of the world, and there some terminologies are common to patients. But if you have a patient here, there are some terminologies that are still here that look like questions for patients, but that you need to still simplify for your own patient. Very important. We looked at respiratory last week. So these are some of the questions. Are you ever short of breath? Has this come on suddenly? Thinking of pulmonary embolism? Have you had any cough? Is the cough, so maybe the next question, is your cough associated with shivers and shakes and breathlessness and chest pain? Okay, it's not even given what I'm looking for. Asking, is the cough productive? So is there any a fluid that comes out when you cough? What's the color of it? Is it green? Is it white? What color? Because if it's green, it shows an infection, and that is really an organic pathology that requires a referral. Do you cough up anything? So that's the question. So do you cough up, and have you had any cough? Is your cough associated with shivers and shakes? Do you cough up anything? So is it productive? So to us, productive, but to them, they won't understand productive. So can you see better way to put it? Do you cough up anything? Have you coughed up blood? So remember when we did pulmonary, it said whenever the cough is productive and there is blood in it, that alone is a red flag. That alone is a red flag, and you need to refer. So what type of work have you done? Occupational lung disease. Do you snore loudly? Do you fall asleep easily during the day? When? Have you fallen asleep while driving? So sleep history. Do you ever have wheezing when you are short of breath? Yes, so that's to show if there is any blockages or restriction of the maybe bronchi or any pathways inside the lungs. Do you have night sweats? Have you ever had pneumonia or tuberculosis? So this is looking at past medical history. Have you had a recent chest x-ray? So whenever there is a chest x-ray, you are thinking that it's possible. It's because there is a problem in the chest that the physician asks for it. So that alone also add to the suspicion that there is a chest problem or lungs problem. Have you had any bleeding or discharge from your breast or felt any lumps there? So looking at cancer, carcinoma of the breast. So I'll just leave this because we have not done gastrointestinal system. I think what I'm going to do is to go get some case reports. I think they will relate to clinicians more than all these theories that we are presenting. But then all these theories are the baseline. They are the basic things that if we understand them, then we'll understand the case reports more. So let's just look at some case reports. But before then, let me just open the floor for discussions, comments, experiences, if we have any in these areas, at least pulmonary, neurological, pulmonary, and cardiovascular. Comments, questions before we proceed.
Good morning, Prof.
Yes, good morning.
Yes,
go ahead, please.
So I have a question. My name is Okibo.
Yes. Sorry?
I said, my name is Okibo Kalisus. I have a question.
Okay, yes, go ahead, please.
Question is, reviewing and used to talk about, especially when you're talking about cardiac conditions, cardiac patients have so in examining red flags now, okay?
Yes, assuming there are red flags.
Assume there are red flags. Is there an
yes, okay.
absolute contraindication? Is there an absolute contraindication to any subjecting the patient to any exercise therapy, or even when you refer, is there an absolute contraindication, or is there you still use your clinical judgment to determine? So that's what I'm asking.
Wonderful. There's going to be a training, maybe towards the end of the year, on exercise testing. So very important. You know, even if there are no red flags, you don't have any red flags. It's very important when you are given patients, even if it's not patients, healthy individuals, that you do clinical exercise testing. to be able to know the threshold. What can they be able to accommodate? Because that is why all over the country, all of you find that people are just doing exercise, they just fall down and they die. There is need for exercise testing. And when you do the exercise testing, you are able to know if someone can be able to. So that is where the contraindications will come. But of course, we have other contraindications from the red flags. But just having those red flags, it depends on what red flags are there. You refer. But our assessments, especially the can put people through exercises. So they can still have the red flags and they can still be able to take exercises. And that is why I said the decisions you can take are either keep the patient, refer the patient, or keep and refer. So if you are keeping the patient to treat and referring at the same time, it means you are going to be treating the patient. Possibly the interventions might be exercise while the patient is still there consulting to get diagnosis to be treated. So those red flags don't say that there is a contraindication. What we say that is a contraindication when you, because you mentioned exercise, that is why I'm focusing on the issue of exercise testing. But with all other interventions, when you read each intervention, we have its contraindications. If the red flags that we have seen are part of it, the contraindications are there, then of course it's an obvious thing. But for the exercise, I want to encourage us in patients that have those red flags, especially cardiovascular, pulmonary, are very, very important before you give them any exercise, that you do the exercise testing, know the level of exercises that you can be able to give them and the dosage that you can give them. For others that don't have those cardiopulmonary, cardiovascular problems, it's also important to do the exercise testing, but then not as important as a priority when you have those cardiovascular, cardiopulmonary problems. So I just hope that I understood the question and approached it well. Okay, thank you. So any other comments or question? Okay, so what I'm going to show you is from my DPT. In fact, many of the things that I'm presenting is from the DPT that we did in Michigan Flint. So just to let you know that some of the documents, I didn't prepare them just directly. That's why I'm not going to send them. The slides that I have, I sat down and developed things, but for this particular case reports, and the issue is even the ones that they shared with us are from that textbook, Differential Diagnosis Screening for Referral by, I think, Goodman and Snyder or something like that. I've shared that textbook. It has many versions. I am not sure if I have the latest version, but if you look at it, you see that many of the case reports are from that textbook. So let me just quickly see which ones I can share. I should have brought them out earlier, but as I've said, I wasn't aware that I was even coming for this. So just bear with me. Let me be opening them as we're walking through the slides. So if there are any questions or comments, it would be good if we can discuss them while I'm opening this. Yes, so possibly as I open them, if they're important, I will just share and we'll discuss. I just saw something about the issue of screening. And I told you, for example, alcohol or yes, alcohol or smoking. You don't just ask whether someone smoke and you just stop there. You need to go further. For example, this one, yes, Goodman and Snyder, a differential diagnosis for physical therapists, 5th edition. So this is screening for alcohol abuse. Have you ever wondered if you should change your drinking habits? Your drinking may or may not be causing you and others problems if it isn't. So so check the box that comes closest to your answer. How often do you have a drink containing alcohol? Never. Monthly or less, 2 to 4 times a month, 2 to 3 a week, 4 or more times a week. How many drinks containing alcohol do you have on a typical day when you are drinking? So none, 1 or 2. So how many drinks? So say maybe cup or pint. of the drink. So just So how often do you have 6 or more drinks on one occasion? How often during the last year have you found that you were unable to stop drinking once you had started? So these are some of the questions that you ask to be able to have a very good evaluation. So say if your total score is 8 points or more, your drinking is putting you at increased risk for alcohol-related health and social problems. There are many options available to you, such as discussing your concerns with your medical doctor, seeking counseling, attending. So exactly, this is what I was trying to say the other day, that you don't just ask people if they drink and just say they are at risk. You need to do an evaluation of the drinking itself. So can you see another evaluation, meaning of evaluation? So all this, you are collecting data. You are asking patients, they are giving you information. But this is like an outcome measure. You see, it's called audit questionnaire, validated, just to use in assessing patients' alcohol intake so that you'll be able to know whether they are at risk. And this is the evaluation. So if your total score is 8 points or more, your drinking is putting you at increased risk of alcohol-related health and social problems. Wonderful. So I think it's important to take note of these things. I'm going to try to send you some of the ones that we are going to discuss today. Someone has asked a question. I don't think I can answer that question, but I'm going to take note of it and get possibly post on the group. On the question, if anyone has any information about it, especially those that are in cardiopulmonary specialty, the question says, how useful are heart rate variability, HRV metrics, in identifying red flag in cardiovascular diseases? And so please, if anyone has the answer, say it. If no one has, then I will make some investigations and possibly post it on the WhatsApp group. Okay, this is another one. I've not shared it, but it's also a screening for alcohol abuse. But I don't think we need to go into details of alcohol assessment. Okay, so this mostly alcohol abuse. So let's see. Come on, aha. So this is pulmonary. So let's see. Bronch. Okay. This will be taking a little time, but the good thing is that we started early, and I think these things are more important than just going through a lot of theories, just speaking and speaking. So let's share another case example. So this is a case example. It's under pulmonary. We have done pulmonary. So let's just go through. I may not read through the whole thing, but let's study it. I hope you can see what's shared. It says bronchopulmonary pain. It's still from that Goodman and Snyder differential diagnosis. So a 67-year-old woman with a known diagnosis of rheumatoid arthritis. Okay, sorry, someone just. Yes, okay, wonderful. Rheumatoid arthritis has been treated as needed in a physical therapy clinic for the last 8 years. She has reported occasional chest pain described as coming on suddenly. So can you see some of those things that we're talking about in the theory? So now it's coming directly from the patient. So this is a 67-year-old woman. So pick the things that you think are important. Maybe before we go to the question and the answers, just pick those issues that you can remember when we treated the pulmonary system. Just read through and pick them. So I will ask for the information. What do you think are important in this? Non-diagnosed rheumatoid arthritis. Okay, read yourself. Okay. So any comments? Identify those important risk factors, symptoms, and signs that you think can help us to know if this is a red flag or a yellow flag. Can we discuss this? You can raise your hand. You can send a chat message. Please, I want to plead with us. Let's participate, because this is the best way that we are going to understand the whole concepts and be able to apply them in patients. Just the first thing is just to list those risk factors, symptoms, and signs from this scenario.
Hello, good morning, sir.
Yes, good morning.
Okay, from the first case that is on the screen, I want to make some comments.
Okay.
The risk factors, the age of the woman.
Okay, 67, right?
67 years. Yes, chest pain. The nature of the pain, it's sudden.
Okay.
Now, one of the symptoms is breathlessness.
Yes.
Then the duration of the pain.
Okay, wonderful. That's a good one. Any other thing that anyone has observed? Let's build a case. I can see a post that says the risk factors are age, gender, and lifestyle. So the age is 67, the gender is she's female, and the lifestyle. So which one is the lifestyle? Please, can you pick that out? I've opened the charts and participant folders. I can't see everything. So just pick that out. Which one is the lifestyle? Is it sedentary lifestyle? Is that what you are referring to? Is there anywhere there that it says that they are sedentary? And the symptoms, so the first ones, okay, are risk factors, wonderful. Then the second ones are symptoms, shortness of breath, threshold of the symptoms. Okay, just like Kate mentioned also some of those. Yes, is it Abubakar? Someone wanted to speak.
Yes, it's me, sir. Good morning,
yes,
sir.
Go ahead. Good morning.
I will add from what she said. She forgot to mention about her rheumatoid arthritis. It's an underlying condition.
Okay.
And then she also developed cough.
Okay,
That
cough.
also,
yes.
Yeah, we should take note of that.
Note of that. Rheumatoid arthritis, did we have that as a past medical history or current history that adds to the red flag for pulmonary? I think it's important because this seems like a case.
Because it
was
can
it
affect
there? It was there, right? Okay.
Yes.
Okay, good. Okay, that's wonderful. So very good. So we have listed them. I can see Mrs. Ogule saying age, gender, associated condition, rheumatoid. Wonderful. So she's also hosting similar to what you have mentioned now. Wonderful. So now the next question is from what is presented here. Okay, chest pain. Very good, Musbao Mahmoud Sani. Very good. Now, from what we have presented here, would we say this is a red flag or a yellow flag? You think it's a red flag or a yellow flag, and why? So we are doing evaluation now. What we did earlier was just to collect information, and that is examination. Now what we are doing is evaluation. Is it a yellow flag? Why is it a yellow flag? Check your connection. Okay, did someone say, okay, I can't hear? Okay, yeah. Okay. Thank you. Yes, Olu told me, I think you need to check your connection. Someone said yellow flag. Do we all agree that it's a yellow flag? Okay, it's a yellow flag?
Yes, okay. It's a yellow flag.
It's a yellow flag, okay. Yellow flag, wow. Everyone is saying yellow flags, okay. So red flag for pulmonary pathology, So someone is saying red flag. Okay, red flags because her general condition has worsened. Okay, red flag because the many risk factors and symptoms make a red flag. Okay, risk factors and symptoms. Okay, because most of it are risk factors. Okay, so that is what you think. But remember, the issue of shortness of breath is there. The issue of the arthritis, rheumatoid arthritis is there. The issue of cough is there. These are all symptoms. But then just having risk factors and symptoms alone does not really mean that it has to be a red flag. There are some that really are important in really making it to look that to be takes breath away.
Chest pain.
Let's go through and see if there is any other thing that they have there that will add to what we have done. Okay, yes. So say questions. Does this patient have signs and symptoms of a systemic disease? So that is one important thing, because red flag should be symptoms that show that there is a systemic disease. So that is one of the things that we need to now look at. So can we go back there and look at it? What amongst all those things shows that there is a systemic disease, an organic pathology? Very important. I think this is what shows a red flag, because if something is a very serious condition, but it is within the scope of our practice, it can still be a red flag, but we are keeping the patient. Okay, so that shouldn't be an argument, because a red flag is a red flag, whether we're keeping it or we're referring it. So let me withdraw that. So red flag, because there are risk factors, symptoms, and because of the sudden onset of the symptoms. Okay, the characteristics of the pain. RA itself is systemic. Okay, so good. Big problem in the pulmonary system. So rheumatoid arthritis can be systemic, but we are talking of now a systemic problem in the pulmonary system, because we are taking the system one after the other. Is there any systemic problem in the pulmonary system? So chest pain is organic. It can be organic pathology, yes, but it depends on the type of the pain. So possibly the type of the pain in this case might be an organic pathology. We talked about the pain of angina and that of myocardial infarction that does not change with this, does not change with that. And I remember we did the same thing with pulmonary, that we said issues of when you breathe increases and things like that. So these are showing a systemic. So I agree that pain, chest pain is organic, but it depends on the type of the chest pain. Yes, very important. So the second thing is that what are the red flags in this case? So this is the issue, and this is what we are discussing. Does this patient need a medical referral? So let's see the brief answers that they have. Further questioning to elicit the potential development of chest pain on inspiration, the presence of ongoing fever and chills, and the changes in breathing pattern is recommended. So can you see that to them, they think there is need for further information. So meaning the information that is there possibly may not really have led for a suspicion to refer. So we need more information to make it a systemic, to have a strong suspicion that it is systemic. So what are those information? So questioning. So I don't think they reported that. When is there any pain on inspiration? The presence of ongoing fever and chills? I'm not sure. Mentioned. So they think there should be further questioning on the presence of ongoing fever and chills. And the changes in breathing pattern is so the changes in breathing changing and things like that. I think there are information related to this, but all they are saying is that it is important to further question the patient on those three areas. So positive findings beyond the reasonable duration of influenza. So meaning, is it just an influenza, or for us here, is it just malaria that made them to have the flu, the fever that they had, or is it a fever that is as a result that the case is? Because just because a patient has fever does not mean that it is an infection from the lung. It could be an infection in another place, not from the lungs. So if you have fever, it can be an infection in the lung, it can be an infection elsewhere. So you might want to find out, because we are focusing on the lungs now, because it's pulmonary. We are assessing the pulmonary system. We want to know if there is a problem from the pulmonary system so that we can send the patient to the pulmonologist. So it's not a case of having systemic disease just generally in the body. I think it's important to take note of this. Or an increase in pulmonary symptoms, shortness of breath. I think some of these things have been reported there. I'm still saying, get more information. So hacking cough, hemoptysis. Is there hemoptysis? So we ask, when you cough, is there any blood? And wheezing or other changes in breathing pattern. Raise a red flag, indicating the need for medical referral. This clinical case points out that clients currently undergoing physical therapy for a non-musculoskeletal problem may be described and disease. So wonderful. Even before we go to the answer, I believe you have answered many of the things that are there. So what they are saying is not that what we discussed earlier was not more questions after what we have gotten in this brief history. So wonderful, very wonderful. So let's see another one. So this is another case, but that's of pneumonia. So maybe we'll just take two from pulmonary, and then after that, we'll go to another system. Let me close this one. Please feel free to call my attention if there is anything you want to clarify or just give feedback. So this is on pneumonia. So, this one is long. So, but let's still quickly just read it. So, a 42-year-old man came to an outpatient place. Let's just read it. When you are done with what is there, just let me know so that I will scroll up. So let's do the same thing. Take note of the risk factors, symptoms, and signs that are important for us to be able to know whether it's a red flag or a yellow flag or red flag. And also if we need to make any further investigations. Okay, are we done? So maybe let's just quickly what are the things that we observe in this case? What do we observe? Can you see something very interesting? Almost all the paragraphs we are going through was looking at the knee. It was the last paragraph that was just something related to the pulmonary system. So what do we think? What's the relationship of the main case that has been treated and the last paragraph where we have noticeable productive cough with greenish/yellow sputum, but no other reported symptoms? Okay. So let's see the questions. Does this patient have signs and symptoms of systemic disease? What are the red flags? Does this patient need a medical referral? Same questions. So given the unusual clear of progress with treatment and development of productive crop. This client was referred to his family physician for a medical evaluation. A one-page letter outlining the therapist's findings and treatment protocol was sent with the client. A medical diagnosis of pneumonia was established. So the physician noted that although the clinical presentation was unusual, knee involvement can occur with pneumonia. The pathophysiologic mechanism for this is unknown. So can you see in cases that initially they were just treating the knee, but because the physiotherapist just observed that cough with sputum that is green, that was the basis for referral. Because as I've told you earlier, when there is greenish sputum, it means there is an infection, and therefore that was the basis for referral. So you don't need to see so many risk factor symptoms and signs. There are some few. For example, a patient faints, just refer. A patient coughs, there is greenish, it's a red flag. There's a systemic disease in those patients. So this is just to show just one or two. In the other one, we saw a number of risk factor symptoms and signs, but it's not in all cases that you will have that. So let's see if we have cardiovascular. Okay, cardiovascular. So palpitations. Okay, so let's very quickly just look at palpitations. I've opened it. That's not what I'm looking for. I'm looking more of a clinical scenario. But I think this, when there are palpitations, those heart palpitations significant and may require medical evaluation under the following conditions. So in what situations that you have palpitations? We discussed the first one. Palpitations last for hours. There are more than 6 episodes per minute. This is one of those that we had in the slides. Age, postmenopausal woman, decreased estrogen, including surgical menopause in younger women. So they have the palpitations and their age is postmenopausal. Personal family history of heart disease, especially sudden cardiac death in family members, and then there is palpitation. Presence of any other symptoms, example, shortness of breath. So this is like a key. When you have palpitation, what other things will you have to make it a red flag that requires a referral and things like that? So to the therapist, other potential causes of heart palpitations, overactive thyroid, caffeine sensitivity, side effects of some medications. And that's why we said drug history. Very important for you to understand what side effects, what interactions effects of drugs are, because they could form a potential risk of having some diseases, menopause, anxiety, and other things like that. So what I just opened now is peripheral. Okay, I think this is important too. Let me just quickly share it. Yes, so this is because we did cardiovascular. So how do you do the assessments? Because you are going to see many of this in the slides. Inspection, comparable extremities side to side, the size of the extremity, the symmetry, the skin. We mentioned earlier about the issue of the bruising. If you have occlusion in the vessels and you don't have any accident, but you can have bruises, it's important to assess the skin. It is important to assess the nail beds, the color, because sometimes the color may change because blood is not getting to the area of the body, the hair growth and sensation. Then palpation, the pulses, the area where you take the pulses, and also the characteristics of the pulses, the rate, the rhythm, and the strength. There's even a scoring for all that. Then arterial insufficiency, of extremities, the pulses, the color, the temperature. Important also, edema. Is there any edema? The skin, sensation, then venous insufficiency are similar. And then what are the special tests that you do? Capillary refill time, arterial brachial index, the difference between the blood pressure in the ankle and that of the brachial, so the upper limb and the lower limb, you take the difference. We are going to see some of those things in the slides that we'll have. So all these things, you can just put them in possibly YouTube, and you'll be able to see exactly the special tests, how they are carried out. And these are things that we can be able to do as physiotherapists, just to be able to know if there is any cardiovascular diseases that need referral, because that's why they have been taught in the systems review course. Well, maybe I will just jump and leave all this, but there are so many resources, really, so many resources. As I'm opening the folders, I'm seeing many things that we can be able to look at. So let's continue with the next system. Please feel free to make it interactive. I think it's important that whatever we're doing, that there is an interaction, so that we'll be able to understand where we are, where we'll be going to. So gastrointestinal diseases. So we should screen for gastrointestinal diseases. What are the red flags? Sudden changes in bowel habits. So the frequency, how often does the patient empty the bowels? Any pain when emptying? Is there any change in the color of the stool?
Is it ready? Okay, I'll soon be there. I'm on my way. Okay, thank you.
Okay, thank you, admin. So, sudden changes in the bowel habits. So is there any blood in the stool, or vomiting red blood? So when the patient vomits red blood, so just vomiting alone is not a case for referral. That would be possibly a yellow flag, but it's not a red flag. You don't have to refer. But whenever the patients vomit blood, red blood, then there is a need for referral. So when you have the sudden changes in bowel habits, blood in the stool. So I would say blood in the stool alone is a case for referral. Vomiting red blood is a case for referral. But what makes it really a red flag for gastrointestinal, having those sudden changes in bowel habits will really add to the information that this is a case for the gastroenterologist. Then the CAS sign, pain in shoulder while lying down and legs elevated. So when the patient is lying down and you elevate the legs, they feel pain in their shoulder. So in the shoulder, and I think it's the left shoulder. So in the left shoulder, is it left or right? Where is the spleen? The spleen, is it on the right side? We'll see that in a minute. So you have pain in the shoulder while lying down and the legs are elevated. So when you have trauma, so there has been an accident and the spleen got ruptured. So when the patient lies down, supine, and you elevate the leg, the patient is going to feel pain in the shoulder. So that is a case of referral. Epigastric pain radiating to upper back. So you have epigastric pain that radiates to the upper back. So for patients that have peptic ulcer, so it doesn't really have to be diagnosed that there has been a diagnosis. Because a patient comes to you, there is epigastric pain and it radiates to the upper back, it's a case for referral, because it could be either peptic ulcer, pancreatitis, so inflammation of the pancreas, or pancreatic carcinoma. So it could be any of this. So it can even be a cancer of the pancreas. So then abscess of iliopsoas muscle. So the hip, the thigh, and the groin. There is pain in the hip, the thigh, and the groin. The iliopsoas muscle moves from T12 to L4. And it then goes to the lesser trochanter. So if you look at the anatomy, you'll see that it passes across where the appendix is. So when you have appendicitis, there's an inflammation of the appendix. it is going to now irritate the iliopsoas muscle. And that iliopsoas muscle will now have an abscess, and it is going to yield pain. How do you know that there will be pain in the muscle if there is no muscle pain at rest? You externally rotate the limb and you resist flexion. So you externally rotate and you apply resistance and ask the patient to flex. So when the patient tries to flex the hip while the hip is externally rotated and the patient reports pain, either in the hip, thigh, groin area, then suspect that there is appendicitis. And that is a case of referral. So when there is arthritis and migratory arthralgias, so migratory arthralgias, you have the arthritis or symptoms of the arthritis in a particular joint, and then it goes to another joint, and then it moves back to another joint. So it's migrating from one joint to another. So when you have arthritis and you have migrating arthralgias, whenever you have that kind of arthritis that it keeps moving from one joint to another, it is Crohn's disease. So when there is inflammation of the sort of the GIT system, so you have those migratory arthralgias. And I think in the last case report that we saw, we looked at how rheumatoid arthritis is related to cardiopulmonary, the pulmonary system. So all this, they are related. You have the GIT problem, inflammation or infection in the GIT, you can have those arthritis and migratory arthralgias. So then the yellow flags, I think those ones that we looked at are all red flags. Whenever you see any of them, it is a case of referral. So for the yellow flags, you have nausea, vomiting, dysphagia. So you have difficulty swallowing. So when you have nausea and vomiting, it could be a neurological problem. And the other day we saw nausea, vomiting, and then the issue of fainting coming together to give a red flag, and possibly one or two more to give a red flag for neurological system. But in this case, you have the nausea and the vomiting. It's not a case for referral, especially you don't know whether it is for gastrointestinal disease. But when you have difficulty swallowing, you have anorexia. Anorexia is when the patient is afraid of gaining weight and they want to reduce the food that they eat. It's a condition. It's not just a normal thing that you just plan to reduce weight. This is comes with a lot of fear and anxiety, and possibly the fear and anxiety that makes them to reduce the intake, and that they become really skinny, emaciated like that. So anorexia. So when people have that, or early satiety, they just begin to eat, feeling very much hungry. They just begin to eat. What they have eaten is not enough to make them feel full, but they just feel full. So when patients report these issues that are related to gastrointestinal disease and they are having nausea and vomiting, all this put together, it means there is need for further investigations to see if there is a red flag. So alternating back and abdominal pain. You have the pain in the abdomen, and then it just goes to the back, and then it comes back to the abdomen, then goes back to the back. So it's not just there in one place, and you can have back pain and abdominal pain at the same time, but this is not so. This one is you have the back pain and then it moves to the abdomen. So whenever you have those alternating pains in the back and the abdomen, it's a yellow flag. You have pain in your shoulder, or the patient has pain in the shoulder. I don't know why I keep referring to you as having the pain. The patient has pain in the shoulder, but it decreases when the patient belches. So, you know, when you eat and you belch, so you have pain in the shoulder, but the moment you belch, it goes down. Or the pain in the shoulder reduces when you take, the patient takes antacids. So this shows that there may be a problem in the gastrointestinal system. Might not refer, but you need to do more assessments to see those red flags that we have done before, if you will have more of symptoms or risk factors that will give a red flag. So shoulder pain that decreases within 30 minutes of eating. So very important if you are suspecting the gastrointestinal system, or just when you are doing the systems review, asking about conditions. When you eat, any changes, any pain, or this shoulder pain. So if someone comes with a shoulder pain, you're not asking, this pain you have in your shoulder, tell me what happens to it when you eat. After 30 minutes, what happened to it? When you belch, what happens to it? When you take antacids, what happens to it? So this would now show if there is involvement of the gastrointestinal system. So decreases within 30 minutes of eating and increases 1 to 3 hours after eating. There is very big suspicion that there might be an involvement of the gastrointestinal system, but that does not really mean that you should refer immediately. Then we have talked about appendicitis, ileoceous obturator abscess. You do some tests, McBurney's test, positive ileoceous and obturator test, positive test for rebound tenderness. So I have a YouTube link there. I would have shared it, but I don't know if you think we should do that. But the McBurney's, okay, let me just share it. I think it's important sometimes if we see it, it helps us to be able to relate more with the assessments. So I'm going to stop sharing this and then share that video.
US permanent residency.
Okay. Okay, sorry, it says it's paused. I don't know, maybe it's because of network. Well, if it's not going to work, then I will just leave it. You have the link. You can listen to it at a, okay, it's sharing now. Okay. Okay, no volume. Uh-oh. Yes, that is also. Okay, no volume. So it's all right. You have the link. I think you can do that at a later time. I don't know what's happening with the technology. Maybe I should have used another browser, possibly. But I think this is something that I've explained part of it. The remaining can be done at a later time. Yes, sorry, Muted, I didn't see where you asked the question, but maybe you said I want to ask the question or something. Okay, that is there. Is there a red flag for ulcer? Because most of the musculoskeletal pain we imagine is as a result of it. Of course, if it's systemic, it's also not systemic. So if you can be able to see the risk factors and some of the signs of ulcer, then it is a red flag. It's a red flag, and it can mimic pain. And we are going to see where it sends pain to, so that when you have people that have pain in those areas, you can be able to ask questions about the symptoms of ulcer. Please, can someone, is it Rita Ogechuku? Please, can you mute yourself? Or the admin should please mute her. Wonderful, thank you. Okay, you can't hear me? Amaka can't hear you. Okay, please, can you let me know if it is from here or it is from her? Is there anyone that can hear me now?
I can hear you, sir.
Okay, wonderful. Thank you. So please, Amaka, check your system. Possibly it's you. Yes. Okay. So I will share back the slides. Yes, okay. Yes, what does increase in shoulder pain 30 minutes after food? So when you have shoulder pain and the pain is there, and when you eat in 30 minutes, within the next 30 minutes, the pain reduces within 30 minutes. So you have eaten now. From the time you have eaten, the pain reduces up to 30 minutes after you have eaten. But after 1 hour to 3 hours, the pain now increases. What this is saying is that pain in the shoulder is being referred from the GIT, from the stomach, or especially the stomach, but it's from the GIT. So why is it that it reduces with eating? Whatever cause in the stomach, the food that you have eaten leads into a temporary relief, meaning the cause subsides and does not affect the shoulder or refer pain to the shoulder as much as when you have finished eating in 1 hour or 2 hours. So it's just a question that you ask the patient. You have shoulder pain. This shoulder pain, when you eat within the first 30 minutes, within 30 minutes after you have eaten, does it change? And the patient will say, yes, the pain really reduces. Okay, what happens 1 hour or 2 hours after you have eaten? No, the pain now increases. What that means is that you suspect that there might be a GIT involvement. Possibly it is what is referring pain to the shoulder. I can hear you. So this is it, the yellow flag. So now let's look at the areas of referral from the GIT. You know, the GIT has different sections. You have the stomach, duodenum, liver, gallbladder, and bile duct. You have the small intestine, the appendix, the esophagus, the pancreas, the large intestine, colons. And each of them, when you have an organic pathology in each of them, it has a specific place in the body that it refers pain to. So the stomach, that's one they say epigastric, isn't it? Just in the middle there, in the middle of the chest. That's if you look at number 1. So that is where the stomach refers pain to. This one that is towards the right, and that's the right, isn't it? It's the right of the patient, or that figure is number 2. That's where you have liver, or you have gallbladder, or you have the bile duct. So liver, gallbladder, bile duct, they refer pain here. We are going to look at biliary, hepatic, and biliary system. So this is just coming in because of the relationship of the biliary and hepatic and biliary system and that of the GIT. But we are going to look at a separate section on liver, gallbladder, bile duct. But this is, so it's just to see the relationship with where the GIT refers pain, that's why it's there. So you have that number 2 towards the right side. And we're going to see a picture so that you'll be able to see the structures. That's what will help you to be able to know what side it refers pain to, because it depends on the side that it is situated. And this one on the left side, at the same level with that of the stomach and the liver and gallbladder and bile duct, which is number 6, is the pancreas. So the pancreas is on the left side, the liver, gallbladder on the right side, while the stomach is the middle, but they are all at the same level. Then we have the esophagus. Just, it's like there are 2 tight bands that are holding my chest, and they are going to show the 2 positions of the tight bands. So that's number 5. When you have an organic pathology in the esophagus, this is where the patient is going to report pain. Then you have small intestine. The small intestine is around the umbilical area, just there in the middle. And then you have the appendix. We all know where the level of the appendix is. That video that I shared, I was trying to assess it from the anterior superior iliac spine, and this point in the middle of it is where you have the appendix. And this is where you have pain when you have the appendix affected. Then you have the large intestine or colon. which is this area that is at the lower abdomen area, and it's wider than that of the small intestine. So it's very important to know these areas where pain is referred from the GIT, because whenever a patient comes to you complaining of pain there, then you need to do this review of system for the GIT to be able to know if there is any systemic problem from the GIT that requires a referral. So that's from the front. From the back, you have the small intestine. I remember earlier we said this is where it refers pain from the front. From when the patient reports from the back, you can have the shoulder and you can have the mid-upper back. Mid-upper back. For the colon, it's still the same level in front and at the back. See esophagus coming even down to the sacral area to refer pain. So you have the shoulder really taking referral from many. We have the small intestine, we have the stomach, we have the liver, gallbladder, and bile duct. We even so these are all areas that that can send pain to the shoulder. So whenever a patient has pain in the shoulder, you need to do really a wide systems review because the source needs to be identified. If not, that shoulder pain will continue. The shoulder is the part of the body that receives, I think, the most referral from the organs of the body. So I just put this picture so that we'll be able to understand the positions of those structures and why they refer pain to where we just looked at. So look at the liver. I think if we go back, I remember the side was right. Look at it, it's the right side. We said 2, liver, gallbladder, and bile duct. So it's more towards the right. I remember the pancreas, we said it refers pain to the left. Can you see 6, the pancreas? So it's more towards, around the center, but moving a little bit towards the left more than the right side. And that's why, because its position is in the middle, but more towards the right side. And then you can see the stomach, its position. If you go back, I would have superimposed the pain patterns, or at least put them on the side, so that we'll be able to compare more. So if you look at the large intestine, that is why it brings pain more towards the lower part of the abdomen, and you have the small intestine above that of the level of the large intestine. And this is where the appendix is. I remember it was there between that anterior superior iliac spine and this point. I can't remember the exact point at this place, but in between the two is where you have the appendix. Of course, you have the rectum and the anus all extending from the large intestine. Then you have the esophagus, and the esophagus is the funniest part that even sends pain from the posterior to around the sacral area. But remember, we said there are 3 mechanisms of referred pain. So it may not be funny. It could be one of those 3. Number 1 is at the embryological level. All structures that are at the same level at the embryological stage, when they push and move to different stages, when pain is there in one, it can refer pain to the other. So right from embryology, they are really very good friends. And even when they move away, one can refer pain to the other. The second is shared pathway. So if you have a nerve that supplies somatic and visceral, so one goes to the muscle, one goes to an organ in the body. So there are different levels, but they leave the spine at the same level. Of course, the nerve will extend longer in one case than the other. Wherever both of them refer pain, supply, then that part can refer pain to the other. So the organ can refer pain to the musculoskeletal structure, and the musculoskeletal structure can refer pain to the organ. And then number 3 is direct pressure. With direct pressure, I've given an example with the kidney being close to the diaphragm, and if it is inflamed, it touches on the diaphragm, and the diaphragm refers pain to the shoulder. So the kidney does not. But if the kidney is inflamed and it irritates the diaphragm, the diaphragm then refers pain to the shoulder because the diaphragm is really very closely related to the shoulder and it refers pain to it. So there is no pathology in the diaphragm, but because the kidney is inflamed and it impinges on it, it now refers pain to the shoulder. So that is why that shoulder, as I've said, very important to consider multiple organs when you have a problem in a shoulder of the patient. So before we look at hepatic and biliary disease, please, at any time, if you have any question, just raise it. I want to share that other textbook where we ask questions. So let's see, what is it, GIT? Yes, I think it is GIT that we just looked at. So GIT, are you troubled by indigestion? Do you have heartburn? Have you had any difficulty swallowing? So that is dysphagia. Have you had any nausea, vomiting, or vomited blood? Remember, in one of those items that we read, we saw that. So when you have gastrointestinal bleeding, you are going to have blood being vomited. So that's a question you ask the patient. Have you had pain or discomfort in your abdomen? Have you had any abnormal bloating or distension? So usually when you eat, especially those that eat, drink. So usually they will have the bloating. But other cases, you can also have bloating or distension. So has your bowel habit changed recently? And that's one of the questions that one of the items we saw. So when you have carcinoma of the colon, it can lead into this. How many bowel motions a week do you usually pass? So have you lost control of your bowels or had accidents? Fecal incontinence. Have you seen blood in your motions or vomited blood? Have your bowel motions been black? So this is the stool. They are calling motion. So that's why I said in our own case, we need to consider what is common in our society so that we'll be able to know what's really relevant to the patients, what they can relate with. So have your bowel motions been black? So the color. Have you lost weight recently without dieting? Have your eyes or skin ever been yellow? So eyes or skin been yellow. Have you ever had hepatitis, peptic ulceration, colitis, and bowel cancer? So this is past medical history. So it is at the level of past medical history that you get this. Tell me about your diet recently. So this is genitourinary. That is the one that we'll look at, and then we'll come back and see what questions to ask. But please, any comments? Feel free to ask. Now what I'm going to do is to open GIT. Let me see if I can identify the folder on GIT. Yes, GI, gastrointestinal and hepatic. Okay, so they have them together. But let me see if they are separated. Okay, maybe esophagus. Yes, esophageal cancer. I shouldn't have even mentioned what the condition is, because if we read, we can be able to now say, okay, we think it is this system, but it's all right. Let me just share. Okay, I hope you can see the shared document on esophageal cancer. Can we read? It will be very important if we discuss it after reading. So please, let's read through. So I think this is a straightforward case because they have even given the answer. But so another important aspect is how to write the referral to the right physician, sir. Okay, yes, we'll discuss how to. I think I kept saying it in the previous classes that we had, I said, when you are writing a referral to the physician, maybe I will even look for a format of the referral. I think we were given in that our DPT course. I'll look for it. But the principle is that you state what risk factors, symptoms, and signs that you see. And you now relate it to that evaluation that we did. To say that I haven't seen this that forms a red flag for a particular system. Systemic problem in a particular system. And that is why I'm referring. So that's it. You are not saying what the diagnosis is. You are not telling them what tests to do. You are not telling them what assessments to do. You are not telling them what the diagnosis is. No. It's just that in this patient that you have referred to me, I've done assessments and I've seen A, B, C, D, which show the possibility of a systemic disease in the gastrointestinal system. And therefore, I'm referring to you for your expert. So that is just the basic principle. That's the basic principle for the referral and how you frame it and you write it. But you can put it in your own language. But the basic principle is that you are just stating your risk factor symptoms that you see and the evaluation and that there is suspicion of systemic disease in that particular system. That is enough. And you send. So if you need more opinion from you, they will ask. And then in your it's okay to say, well, I think if you do this test or that, it's fine. I remember Sabiu mentioned that, and I'm happy that he did not mention it because he said, I went to him and said, this is a situation, this is what I've seen. And then I said, okay, what do you think we should do? And then he said, why don't you do this test? And then they went ahead, they did the test, and they found out that it was positive. I think it was Pott's disease or so that he was talking about. So that is the spirit. Okay, so I think this is straightforward, as I've said. It was a musculoskeletal problem, total knee replacement, but there was a report of swallowing difficulty, the issue of, loss of appetite, difficulty swallowing, and loss of weight. So all this put together have formed a basis for a referral to the physician. And when they went back, a diagnosis was made. Esophageal cancer, as big as that, as sensitive, as serious as that. And it was the physiotherapist that made the referral. And I think most of these are actual cases, I think, that they reported in the books, in the book, that Snyder, Goodman and Snyder. So very important, please. Go through it. There are so many of these case reports. In fact, if you look at it, case example 8.2, this meaning is chapter 8, and the second case example in that chapter. And they are given reference to the diagnosis for physical therapists by Goodman and Snyder. Very important, look at that book. It's going to help you a lot with systems review and the issues of referral and the issues of discussions during ward rounds. You go there, you don't just keep quiet. You are speaking and they think, is this a medical doctor or is a therapist? Someone might even challenge you. You are not a medical doctor. Why are you talking about all these things? I say, well, I'm just trying to do a screening because when patients come to me, I screen them and it helps me with the referral that I send to you. So you two, you make referrals. You don't just sit down there like a technician and only receive referral. No, I don't do that. I screen them. And that is what really I would like to see in the next few years. That's why I'm taking this very, very, really serious, even though it's not in our curriculum. Yes, so any comment, question? Always looking at the and I don't know if Hafiz is there. You said you are going to use link the Zoom to another platform where others can. So if they are not able to join, because I can see 9900 since, I guess the esophageal cancer must have metastasized to involve bone. Well, possibly, well, I doubt if that's the case. Let's look at it again. Okay, I've already stopped sharing because it says an obese 88-year-old woman with a total knee replacement was, before you do total knee replacement, it takes a while managing the knee up to the point that the last result is to do a total knee replacement. Now, what I don't know, let's see, over a period of 2 or 3 weeks, each daughter commented on how much weight the mother had lost. When questioned, the client complained of a loss of appetite. Now, we need to ask, it says over 2 or 3 weeks. These symptoms were there even before the total knee replacement. If those symptoms were not there, there is a possibility that the total knee replacement was not related to the cancer. It was just a musculoskeletal problem because she's 88 years old, the degenerative changes, whatever reason, she had total knee replacement. But coincidentally, around the time after the total knee replacement, she developed these symptoms and it was diagnosed as esophageal cancer. So you are right. It's possible it could have had any thing to do with the total knee replacement. It's possible it doesn't have anything to do with it. But I think further questions and investigations may be able to reveal that. Okay, so I will share back. Yes, some are joining through the YouTube channel. Oh, okay, wonderful. Thank you, Hafiz. Thank you, Hafiz. That's why I've not really seen a lot of comments and complaints on the WhatsApp platform that people are not able to join. So I think, as I've said, I really don't want us to go through the route of having so many joining one workshop. I really need to know that people understand, and I can only be able to do that with a relatively small number. But 160 or so, well, maybe we can manage. But if we have anything more than that, we separate the classes. I would rather do it twice than do it once, and many people are not able to follow, and I can't be able to know and guide them. That's why I keep insisting that we interact, because that is where I get to know if people understand things or not. Please hope in the diagnostic textbook there's example related to pediatric. Oh, there are. In fact, at the end of this presentation, you are going to see pediatric. In the last workshops that I did, it was not there. I remember someone from pediatric queried me, and I had to go back quickly to add pediatrics. So even in this slide, there are pediatrics, and in the textbooks, there is a section on pediatrics. And I'm going to give you even case reports on pediatrics before we leave. I'll show you of that. Cases for us in pediatrics. For how to have knee pain, reduced weight bearing, reduced weight bearing. Okay, reduced weight bearing can also predispose to joint stiffness or secondary knee pain from altered biomechanics. Yes, and okay, what I thought you were even going to say was that because of the knee, she may, no, but that will not lead to reduced weight. I think what was reported was reduced weight. Yes, okay. So your case, yes, sure. So for her to have knee pain, reduced weight bearing can also predispose to joint stiffness. Okay. Because of the knee pain, she's not bearing weight and she can predispose to joint stiffness or secondary knee pain from altered biomechanics. Yes, very true. Very true. Okay, this is it's not to the general house. I'm trying to figure it out. Okay, that's all right. So thank you. So let me share so that we continue with the next system. Please, I want to plead with you. Let's interact. Let's hear your opinions on things. It's not everything. I really appreciate that argument that we had on the issue of what is it called? It was yesterday. I don't know those that joined in the first one. We also had discussions, but that of yesterday was more intense about the issue of the clerking process, the APTA template, whether we should have chief complaint earlier or later. I truly appreciated that because it shows concern for the patient. So what is important to the patient? So there are different varieties of opinions and justifications, and the discussion is what is now helping us to bring out those areas that we didn't have in the past. And now it is making us to now beginning to have thoughts. Should I go this way or should I go this way? And as we continue to move, we'll continue to have change in perception, change in mindsets, little by little. But it is a discussion that will help us to be able to bring out issues. I usually tell people, when you see me arguing, I don't know the thing. So I want to really stimulate the other person to give me more information. No, that's not how it is. Then the person will say, no, this is how it is because of this and this and this. What I'm looking for are those reasons and those justifications. But if I know it, then why do I need to argue? Unless if I want to educate the other person, I think it's important for the other person to be educated. So I think I appreciate those discussions, different opinions, our experiences in the clinic. Many of you have more experience than me in the clinic, believe me. More into academia and administrative things have made me not really be in the clinic as much as I would love to have that. So many of you, I will have the theoretical aspects, bring them out, but you will have more of the clinical experiences. Sharing them is going to add a lot of value to what we are doing here. So thank you. Let me go back to the slides. Okay. So screening for hepatic and biliary disease. Remember earlier when we were doing the GI, we saw in the picture the issue of liver and bile duct and whatever. So, but this is where we are going to look at them specifically in particular. And I hope I've shared the right slides. If not, just let me know. So when you have edema, or ascites, so we know ascites, I would have shown picture, but you can Google it. Ascites, you have accumulation of fluid in the stomach and it protrudes. And through palpation and other means, you are able to know that it is accumulation of fluid or edema in the stomach. So when the patient has dark urine, that is why it's important to ask the patients about the color of their urine when you are assessing the hepatic and biliary system. So what is the color of the urine? Is it dark? Then for the stool or feces, it's light colored or clear. So the urine is dark. Lori, help us mute, please. Oh, yes. So the urine is dark, but the feces is light. Then there is right upper abdominal pain. So abdominal pain on the right side and upper side. So when you have that, remember we said hepatic and biliary, we saw them on the right side. And that is why they refer pain to the right side of the chest. So since it's on the right side, if you are having direct palpation, just like we did with the appendix, for this one, you are going to have it instead of the lower part of the abdomen is on the upper to the right. So the same thing, because the appendix is also on the right, but lower part of the abdomen for the hepatic and biliary system is upper part of the abdomen and on the right too. So this is a red flag. This is a red flag, especially if you have other gastrointestinal symptoms such as vomiting, the issue of difficulty. So there are some of those symptoms, just trying to think which ones are relevant to the hepatic and biliary system. So confusion, so the patient is confused. You have muscle tremors. You have muscle tremors. So those irregular twitches, we know the tremors, just like Parkinson's disease. You have tremors. Then you have what is called asterixis. So with asterixis, for example, what you do is to ask the patient to put their hands like this. I know I'm on video. I will have gone to show you a video, but since you can see, if you ask the patient to do like this, and you use your hands to pull back, when you release, you'll see the clonus in the hands. So you put the hands in extension, and then you now further extend. You release, you'll see the clonus. So that's asterixis. So it's myoclonus, irregular lapses of posture, abnormal ammonia metabolism is what causes this. So when the hepatic and biliary system is not able to metabolize ammonia normally, then you are going to have those confusion, muscle tremors, and asterixis. So whenever you have those, the only thing is that we know muscle tremors and myoclonus could be neurological, and therefore you need to have, well, it's as it is like this. They say it's a red flag. It's a red flag. But left to me, I would say confusion, neurological, muscle tremors, neurological, asterixis, neurological. So I would have loved to see something, just like we did in pulmonary and cardiovascular. That we said when you see confusion, you see nausea and vomiting, it can be neurological, but then you now see shortness of breath or difficulty breathing. You now say, okay, it's cardiopulmonary. You see the palpitations or something like that. You now say, okay, this is cardiovascular. So in this, I would have also expected to see that, but this is what we have. You have the confusion, muscle tremors, the asterixis, says a case for referral and for hepatic and biliary disease, not for neurological disease. So when you have pruritus, itching. So you have itching, you have jaundice. You have jaundice, you have pallor. So for jaundice, you see yellow coloration. The body is not able to excrete. What is it that when you can't excrete it, you have jaundice, you have the yellow coloration, or you have pallor, the patient looks pale. They are orange or green skin. Now, all this, remember, we need to find out what is it in dark skin people that will help you to be able to see all this. You say pallor, or green skin or orange skin. I know even in dark skin people, you can be able to see the vessels. Sometimes you see them looking green. So I think it's important for us to have something that shows a difference between what they report in textbooks for whites. If anyone has any experiences that they want to share with us, I think this is important in making an evaluation. If you can't see it, how can you make evaluation? So very important. So bruising, I think we have discussed this earlier about when we were discussing cardiovascular, especially the vascular part. So you have bruising without accident. So it's not an accident. You just see bruising in the skin. Spider angiomas. So you have abnormal collection of blood vessels. So the people you see them, especially the light skin, that you see many vessels, just like a spider web. Near the skin surface. So palmar erythema, red palms. So the palms are red. So because the palms are fair, lighter in complexion than the dorsum of the hand, usually even in dark skin people, you will be able to see the change in coloration. You see the dark, the redness in the palm. So you're seeing all this forms a red flag for hepatic and biliary disease. Yellow flags for hepatic and biliary disease. You have anti-inflammatory and minor analgesic agents. So patients that are on anti-inflammatory and analgesic agents and they are on it for a while, it could be a risk of having drug-induced hepatitis. So very important to check the history. Are you inflammatory or analgesics? How long have you been taking them? Then do more assessments of the hepatic and biliary system. Post-operation, people that have had operations may be at risk of having non-viral hepatitis. It's important to screen the hepatic and biliary system. Pain at thoracic spine, between the scapulae, right shoulder, right, can you see the shoulder appearing? As we have said, we saw it in pulmonary, in cardiovascular, we saw it in the GI, and now we are seeing it also in hepatic and biliary system. So right subscapular area, we are going to see pictures of all those. So tenderness anteriorly over 10th, 11th, and 12th ribs. So that is where the gallbladder is. So if there's gallbladder impairment, you palpate between the 10th to the 11th to the 12th ribs, and you feel pain, and then it's a yellow flag for a problem in the hepatic and biliary system, particularly the gallbladder. So these are the pictures. Can you see the shoulder? The shoulder always. And you see the right side, and we have seen this already when we were looking at the GI. So it's there on the right side because the liver is there on the right. So this is still the right side. So you have the right shoulder. So whenever there is right shoulder pain, think of the liver. You have, that's where they were saying interscapular. The scapular and then upper thoracic. Then you have this other subscapular. This is subscapular, and this is the mid or lower thoracic. So the gallbladder is one that refers pain to the mid scapula, interscapular, to the shoulder, and to the subscapular, while the liver refers pain to the shoulder, the trapezius, of course, the trapezius for the gallbladder too, and then the lower thoracic region. These are areas that the hepatic and biliary system can refer pain to. So any pain that comes, patient that comes with a pain in any of these areas, always screen for the biliary and hepatic system. But there's a say that if your palm or tip of the fingers are reddish, it means you have enough blood in your body. Oh, yes, sure. But what we are looking at is we know what is normal. So you can see the hand of someone and say, oh, this is normal. But when it's beyond what is normal, then you know there is a problem. And the patient can also tell you that, well, what I have, I mean, he's 40 years old, 45 years old. And for all those years, he knows the normal color of their hand. And just recently, it becomes much more reddish. So you compare. That is why sometimes you compare between the right and the left side. You say that, okay, have they been the same? Yes, they have been the same. Okay, but now this one is thicker than this one. Then possibly there is hypertrophy or atrophy, or there is this or there is that. So I think it's about comparison. Since it's not a child that is just born, it's someone that has been observing the palms for a very long time. Yes, so I just also got a picture so that you can see the liver and the gallbladder, that right side, just like we discussed, but then look at its relationship with the other as parts of the GI. You have the pancreas, and other sections. Yes, thank you. So this is the picture. So this urogenital system, but I think before we go to urogenital system, let's look at it's still 11:20, so we can still do more before we go on break. So let me share that textbook. Let's see if there is anything on hepatic and biliary system. Oh, this is genitourinary. I think the earlier one we did was gastrointestinal. There possibly may not be hepatic. It's hematological, musculoskeletal, endocrine, reproductive, neurological, the elderly. I was hoping to see pediatrics. Let Mutiad not give me a query here. Okay, there's the textbook, not me. But there's supposed to be pediatrics there. But the other textbook, I assure you, Goodman and Snyder, there is pediatrics, definitely in that one. Yes, okay, so we'll leave this textbook until we get to genitourinary, the urinary system. But let me open, see if we have hepatic system. Yes, urogenital, not hepatic, 8. Oh, this neurological, okay. 9. Endocrine, 10. Oncology, hematological, pediatrics, geriatrics. Okay, so there's no, I think because GI is very much related to hepatic, So they are, oh, it's here, but there are no case reports. It's here, but there are no case reports. So we'll just go straight to another system. But is there any question, any comment? Any question or comment so far? Am I too fast, too slow? Is there anything problem about the delivery? Okay, so we'll look at the urogenital system. Okay, so with the urogenital disease, as I've said, whenever you see blood, usually that on its own is a red flag. So we saw vomiting blood, blood in stool for the GIT, blood in sputum for the pulmonary. Straight away, I know that's a strong possibility of an organic pathology you refer. So the same thing with the urogenital disease. A red flag, any amount of blood in the urine. The moment the patient reports they urinate, they see blood, it's a red flag. So when you have cervical spine pain and urinary incontinence, for me, urinary incontinence on its own is a red flag. Possibly it's because someone may have a urinary incontinence that is not organic pathology in nature. That is possibly why there's need for other things put together to be able to make it a red flag. So when you have cervical spine pain and you have urinary incontinence, it is a red flag. When you have saddle anesthesia, so you have anesthesia around the sitting area, and you have bowel or bladder incontinence, that is a red flag. It's a case for referral. So what are yellow flags for urogenital disease? Fever, chills, fatigue, malaise, anorexia. I've explained anorexia, the issue of eating and not eating and having excessive weight loss. So the weight loss. So all this, you see them think of the urogenital system because it could be an infection in the urogenital system that is leading into the fever, the chills, the fatigue, and what have you. Or it could be a cancer of the urogenital system. So all those are organic pathologies. So when you see this, they are yellow flags, then you need to ask questions about urination, the color, the frequency, and other things that have to do with the urogenital system. So it is when you have those together with this that it now forms a yellow flag. Unilateral costovertebral tenderness. So the unilateral costovertebral tenderness from the back, you have the vertebral column, and then you have the costal region, the ribs. So the last rib, the top rib, and you have the spine. So that area, you will tap that area. So possibly you punch it a little bit, and the patient will report pain. So that is testing if the kidneys are inflamed or not. So that's the unilateral costovertebral tenderness. So you also have low back, flank, inner thigh, leg pain. So these are the areas of the musculoskeletal system that pain is referred from the urogenital system. We are going to see pictures also. So when you have change in color, so the urine color changes, just like we saw earlier, that we said it becomes dark. Consistency, someone that urinates just once or twice, maybe let's say twice or thrice in a day, now urinates 6 times in a day. The consistency has increased. Or when they urinate, it doesn't smell. But now they observe that when they urinate, there is smell, or there is reduced volume. It will take them 20 seconds to void. But now, the moment they start, within 5 seconds, it stops. Possibly, it will have to be because the consistency has increased. They will have to come back and still void again until the whole thing is emptied. But the consistency has increased, but the volume has reduced. That's of the urine. So these are questions to ask the patients. Yes, because whenever you have bladder, or where does the nerve that supply the urogenital system comes from? Remember earlier I was saying the issue of the roots in the spine. So each root, you are going to have a nerve that goes to the musculoskeletal system and a nerve that goes to the organs in the body. So those nerves that come from those cervical sections, and they go and supply the bladder or the rectum or the urogenital system. If you have a problem in that cervical spine and that affects that nerve, it's just like feeling referred pain or pain in the limbs or abnormal sensation when you have low back pain. Why should that be? Because you have an impingement on a nerve that supplies the musculoskeletal system in the lower limbs at the lumbar region or the upper limb at the cervical region. So if the urogenital system, the nerves leave before you get down to the lower level of the lumbar area. And that is why they are talking of the cervical spine. Because if you go down to the lower lumbar areas, the urogenital nerves would have left that level. And whatever happens there is not going to affect the urogenital system. But at that level of the cervical spine, that is, the nerves are moving down. And if you have a problem there, it can compress on the nerve before they go down even to where they are going to exit the spine. So I think that is the relationship between the two. So when you have spinal cord injury, you have your urogenital system problem. You have a bladder incontinence and you have bowel incontinence. So either it affects the spinal cord or it affects the root where the nerves lead. So if it is at the cervical spinal cord, it is not the root because it has not got to the point where the nerves will lead to go to the urogenital system. But there could be compression of the cord or any other problem that will lead into affectation of those nerves that are moving down before they exit, before they get to the root. Yes, so change in size and shape of testicles or penis. So very important, ask those questions. These are the areas where I will say people may feel embarrassed to just talk about them. So you ask them, so what's happening to the size and shape of the testicles or penis? Change in smell, volume, and consistency of ejaculate. So it's not just the urination. It's not just the urination. You also find out about the ejaculate, its consistency, its volume, its smell, and all that. So what are the areas where pain is referred? With the urogenital system, it has 3 different sections. You have the renal section itself, you have the ureter, you have the urethra, you have the ureter, you have the bladder. So there are 4 different regions. The kidneys, and then you have the vessel, the tubes that join the kidneys and the bladder. And that is the ureter, isn't it? Ureter. And then you have the bladder, and then you have from the bladder externally going out, you have so urethra and then urethra, then ureter. So at the level of the renal, where does it refer pain to? These are the areas. So can you see still that shoulder, this shoulder, really, when you have patients with shoulder pain, multiple reasons, multiple sources. I didn't even remember that the shoulder can still come down to the level of the kidney. So we still look at the shoulder. So posterior subcostal region and costovertebral. region. So subcostal and costovertebral region. Then you have low back. So this, the low back. So this, we're looking at it from the back, the low back, the flank, lower abdominal quadrant, the lower abdominal quadrant. Ipsilateral groin. So it comes down to the groin on one side. So that is if it is one kidney at that side of the kidney. If you have both kidneys, then you are going to have it on both sides. Kidney pressure on diaphragm. Oh, yes, I remember. I even said it earlier that it's not the kidney itself that refers pain to the shoulder, but the kidney will get inflamed, impinge on the diaphragm, and it is the diaphragm that will now refer pain to the shoulder. Yes, sorry, I think I mentioned this earlier. So that is why you have the shoulder. But the kidney itself directly will refer pain to the subcostal region and the costovertebral region, and then the low back, and then the lower quadrant of the abdomen, and also down to the groin. So whenever patients mention pain in the back and they put their hand up to the abdomen and they take it down to the groin, I would just begin to suspect that there is a possibility of a renal problem. So this is the ureter. So the ureter, costovertebral angle, and so it's less than what we have with the kidney, but it's a similar pattern. It goes down to the groin. Even the testis and the labium is affected with the ureter. And then the ureteral ureteral pain. So it's more localized around this area, and also more centrally at the back. But you also have the prostate. The prostate is the area suprapubic, so suprapubic, and then at the back is the sacrum. But you also have the inner thighs and you have the testis. So those areas where you have pain referred from the prostate. So I just tried to put in this just so that we'll know the positions. And as I've said earlier, I should have put in those pictures here and here. That will help us to be able to see the positions and the areas they refer pain to. That possibly will help us to understand a particular pattern, and we'll be able to remember easily when we see pain located in a particular area, what organ of the body that we should suspect. So you have, I think I was mixing up the ureter and the urethra. So the kidney, the tube that connects the kidney to the bladder is what is called the ureter, while the tube that empties the bladder is called the urethra. So you have the two kidneys, and then you have the two ureters, and then you have one bladder, and you have one urethra emptying the bladder. So before we go to endocrine, I think we'll go back and we'll look at, I'm going to force you to interact. I need many. We have more than 100. 4, 5, or even 10 may not be representative of the whole participants. So I really need to have more participations that will show that there is an understanding, and if there are problems, we'll be able to know. So I'm going to share let's start with the textbook, because we have genitourinary system there. What questions we ask the patients directly from that? Yes, so this is it. Do you have difficulty or pain on passing urine? So I think we have seen that in a more technical way, but this is something that is more patient related. Yes, I will give a case report. I just want to ask the questions and then I will give the case report. Yes, thank you. We'll take as many case reports as possible at this point. In fact, we did neurological. We didn't take case reports. I think we did pulmonary and cardiovascular. So at this point, we'll take genitourinary, we'll take neurological, and then possibly if it's time for break, we'll take the break. And then when we come back, we'll start from which one is it that I saw as the next one? Endocrine diseases. So genitourinary system, do you have difficulty or pain on passing urine? Is your urine stream as good as it used to be? So as it's flowing, is it that, you know, some people, they will be beep, 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 it will go out, then it will stop, and then it will go out. So is it as good as it used to be? And does it continue until it ends, or they stop and then it comes back? Is there a delay before you start to pass urine? Yes, so this applies to men. Is there dribbling at the end? So usually at the end, you find out that a beep, beep, beep comes, stop, comes, stops. So these are questions that help to know if there is any problem with the urinary system. Do you have to get up at night to pass urine? Some people will just urinate and then until morning. But people will wake once, some even twice or thrice in the night. Are you passing larger or smaller amounts of urine? Has the urine color changed? So I thought the first one was about color. Oh, it was difficult. So this is about color. Have you seen blood in your urine? Yes, we said that's a red flag on its own. Have you any problems with your sex life? So that is looking at the ejaculate. Difficulty obtaining or maintaining an erection. So have you noticed any rashes or lumps on your genitals? Have you ever had a sexually transmitted disease? Have you ever had a urinary tract infection or kidney stone? So this is a past medical history. Are your periods regular? That's for females. Do you have excessive pain or bleeding with your periods? That's for females. So that's this. So let's see the case report. So this is genitourinary. Yes, urogenital. Okay, I think I can open the textbook. I don't have this in the folders, but since I have the textbook, I'm going to open the textbook and then we'll look at it directly from the textbook. And I've sent the textbooks on, yes, question? Okay, yes, sure. What is the relationship between cervical spine? I think I've answered this. Okay, this is not the current question. Can you give us a case walk? Yes, I will give. A question from Dr. Mistura. Prof, can you please explain that in relation to women and urogenital? So can I explain what? Is it the whole thing? Now, we are looking at, before you, if there's any specific that you want to send, but I think what you mean is that what we have just looked at, screening the urogenital system, or possibly these questions that we have asked. Remember, the basic principle in this screening is to identify a systemic disease. So anything that shows that there is a systemic, okay, like a PID. Yes, so you have an infection. You have inflammatory processes going on. Or if you have a tear, you have a breakage. All these are systemic problems. They are organic pathology problems. And what you are doing here is to try to identify that issue that is an organic problem, because it's not within the scope of your practice to treat it. You want to refer it. So if there is anything, either for males, peculiar to males, or for females, you are asking those questions to be able to identify if there is an infection. So anything that shows there's an infection. For example, in the lungs, we say when the patient coughs and it's green, it shows there is an infection. So for this, if the urine color changes, we said if it's dark, or if the stool, that is for GIT, is light, or if it smells. So either why should the urine smell? There must be an organic problem that will make a urine. So when you have movement impairment, There is no reason why a urine should smell. So when the urine smells, when the ejaculate smells, when there is discharge from the urinary or the reproductive system, whatever it is that we see, that those things that show that there is a systemic problem or organic pathology, a problem, then we refer. So that is just the basic principle. So whether it relates to a man or a woman or it's a general thing, we are trying to identify what shows that there is an organic pathology. So the PID that you said, I'm happy that you even mentioned that. So it's a straightforward. What are the symptoms that shows that there is an organic pathology? Yes, so I'm trying to share that textbook. So there are two differential diagnosis. I'm not sure which one is the latest, but I will just open one because all of them will have those case reports. Okay, this is the 6th edition, and I think that should be the latest. Even if it's not the latest, it is later than the second one that I have. So let me just share it. Yes. Good. So I hope you can see it. This is the differential diagnosis for physical therapist screening for referral. It's the 6th edition. Just let me know if you can see it. I think it shows here that it is sharing. So it's a lady, Catherine Goodman. So for this one, I think the other one is Snyder, the second author. But this one, I think possibly Snyder was not able to join. And they have John Heck and Rolando Lazaro. Yes, okay, another question possibly. Do you have tips on patient education in a case where they have to be referred as a result of a red flag being identified? It is possible for a patient to be alarmed when they are told their treatment has to be paused because of something that we have identified. Now, number one, let me say this. It's not in all situations that you pause your treatment. I think a similar question was asked about the issue of contraindication. Please, in all situations that having and I think I see this a lot with stroke patients. You just see a patient that has high blood pressure. You just say, okay, we'll stop everything, we'll refer the patient. When there are researches that have shown that exercises that we give help chronic effect is to reduce the blood pressure. So you have an acute effect that just raise it to a few millimeter mercury. So if you look at what level is it that the patient will be at danger of having another health condition, then you now look at the level that you have. If it goes up by 2 or 3 millimeter mercury and it cannot go up to that level, it's still in order to give exercises to the patient because the chronic effect is to bring down the blood pressure. So you can treat, you can help bring down blood pressure. Why do you just refer the patient and you stop seeing them? And another thing, is it just exercises that can increase blood pressure that physiotherapists do? It's not. There are a number of other things that we can be able to do to the patient. Maybe there's 1 or 2 things that we say we stop until we get a report from the. So please, it's not in all cases that we have a red flag that we stop seeing the patient. That's why I said the decisions we can take, I said we are 4 in the first lecture. I said, number 1, we keep because we have not seen any red flag that requires referral. We refer. We have seen the red flag, and there is nothing that shows suspicion of movement dysfunction. And therefore, we are not keeping. We are only referring. For example, in the first case that we are keeping, we realize that someone, because of sustained alignment, is beginning to have back pain or neck pain. And we realize that there is no organic pathology at all. All the patient needs is positioning and then physical treatment to relieve the pain. It has not reached to a point where it has any inflammatory processes are coming up or any tear or any impingement that manipulative therapy cannot take care of. We don't have any of those. And therefore, we keep the patient, we treat the patient. But in another case, we do assessment. The patient has shoulder pain. But from our questions, we realize that he has a problem in the inflamed kidney. and the inflamed kidney has impinged on the diaphragm, it is referring pain to the shoulder. All our physical tests, palpation, movement are not showing anything positive, meaning it's not movement dysfunction. And therefore, the only thing, we refer the patient. But we have another patient that we have the shoulder problem, it's there. But during our assessment, because we know pain can be referred from the lungs, from the heart, from the kidney, we found out that there are symptoms of a heart problem that is organic. We keep the patient and treat the shoulder, and we refer the patient to be able to get treatment for the heart. And therefore, okay, come on so date. Now you go to the cardiologist, he will now give you another date that does not coincide with the date that you are coming to see me. You do that. Number 4, of course, is consultation. So at least this last part is the one that makes me to give these long explanations. But the first part says, do you have tips on patient education? Now, every patient will be glad and happy. And I said this, I think maybe it was yesterday, not on Saturday. Every single patient will be very happy that I come to you with a particular problem. I think I was explaining this yesterday because of that argument that we had about the template of the APTA. Which one comes first? So I was saying that if you ask the patient the chief complaint, you get biased, you miss diagnosis. And someone was even saying that, well, even medical doctors, they are doing first contact. But why do they all ask for the chief complaint? And then I told him, I said in last week and yesterday that we had people testimonies of experiences that they saw missed diagnosis and misdiagnosis. I said, if the medical doctors are doing the right thing in the plan of assessment, they will not be missing diagnosis or having misdiagnosis. So if a patient comes and you try to explain to them that naturally, because of our ways of life and the challenges that we have, many risk factors, it is possible that a patient might come with a problem that they have symptoms. They are out there, they are seen, and it is identified. But it is also possible to have underlying problems that are not seen. And if you leave those problems to be there until they manifest, then at that time, it will be more problematic to treat. You will spend more. You may be hospitalized. You may be this, you may be that. And therefore, what I'm going to do now is to try to assess you in such a way that I will identify the problem that you are presenting with. But let me also be able to identify if you have any other underlying diseases that will require another person's expertise. They will appreciate that. You can even give them example. So I've experienced this in a case like this. The person came with a back pain. And in our assessment now, that case, a case report that we looked at, the patient came with a knee pain. But the physiotherapist was able to identify that they had problems and referred. And later, they diagnosed esophageal cancer. Tell me if that patient will not come back to the physiotherapist and thank the physiotherapist. It's because of you that I've gotten early diagnosis of esophageal cancer. If not because you referred me early by asking those questions and identifying that I may have that problem, it may not have been diagnosed early. So some of the things that we need to do is to go and read the consequences of late diagnosis. Very important. How I wish we'll have time to have a workshop just on that. The consequences of late diagnosis. If we know those consequences, it will help us to be able to educate our patients that if we don't diagnose early, this is the consequence. And you'll find out that no matter how much questions you will ask, no matter what decision you take to send the patients to other places, they will truly appreciate you because, so education cannot come if the person educating the other does not have the right information with them. So I think it's about getting the right information. It's about having the justifications. It's about understanding what the consequences are. You now put it in a lay language and you give it to them. I believe they will appreciate it so much. Yes, wonderful. So people are saying I can see. Okay, so the document. So we'll go straight into the book. I just hope, okay, it should be a comprehensive one. So let's just go to the As I've said, I'm sorry, didn't know I'm going to do this. I would have prepared, get the pages and everything so that we just go straight. We even screenshot the pages so that we just present it instead of scrolling to go there. Questions and screening for. Okay, so can you see the appendices? Many appendices. Special forms to use, special tests. A very rich form, very rich one. Introduction to the screening process. So what it was gastrointestinal? No, hepatic and biliary. So see the hepatic and biliary that we couldn't get earlier. So we'll have, is urogenital. Is it urogenital that we just finished? Yes, I think it was urogenital. Yes, urogenital. So let's look at the two. Screening for hepatic and biliary, 337. Then screening for urogenital disease, 360. So 337. A nice search. 330. Okay, let me just use this. 337. So can you see even more pictures, more information? 337, sorry. Many pictures. Refer pain to the area of sensory distribution for the 11 thoracic nerve. So there are much more information than even what I've presented. Very interesting book. So you see all those tests that we looked at for the rebound tenderness, Bloomberg sign, they're explained here. Pancreatitis, clinical signs and symptoms. So let's just see if we have them here or if in these books. I know the old one that we used, it was in the text that they have the case reports. It's possible in this one, it's at the end in appendices, but let's see. Large intestine and colon. So these are all things that are presented. These are the pain patterns, the location, the description, and where it's referred. Pancreatic pain. So gastrointestinal pain patterns. Okay. So case study. Sorry, I can't even. Do you have document on the consequences, sir? Well, I'll look for it. I believe there should be, but it's something that I need to search to be able to get that. Okay, urogenital. So it's urogenital, but I think the ones that I'm looking at here seems to be gastrointestinal. Apologies, someone keeps calling, so it's just diverting my attention. So this is Crohn's disease. This is GIT. This is IGIT. Okay, that is urological. Or it's Crohn's disease. This is just assessment of the urological system. These are practice questions. Let's see what is next after that. Apology. Okay, this is hepatic and biliary. Wonderful. So this is the one that we're looking for. So very good. Can you see the pictures? I think someone was talking about the coloring, that some people, it's even good to have that color. But look at this. Excessive, you can't see that and see it as normal. So it's an excessive coloration. It's red. And that is what is abnormal, not just the normal coloring. Remember that asterisk that I explained. So this is how they are trying to depict it. That's the case, I think, of ascites. Yes, the case of ascites that we mentioned. So very, very good book, actually, because it gives you with explanations of things and even pictures. And this is there on the case example. So we have case example, clinical signs and symptoms. So you even have clinical signs and symptoms. So extreme fatigue, anorexia. Remember, we mentioned fatigue, anorexia, this for hepatitis, fever, arthralgia, right upper abdominal pain, clear colored stools. We have mentioned a number of this. Dark urine, we mentioned all this. Icterus, jaundice, headache, pharyngitis, alteration in senses, and all that. So let's look at a case example for hepatitis. A 43-year-old man, 1 year following traumatic injury to the right forearm. So can you see, it is a traumatic injury to the right forearm. So it's a musculoskeletal case. Underwent surgery to transplant his great toe to function as a thumb. The surgery took place in another state, and the man who had been a client in our facility before surgery returned for post-operative rehabilitation. Complaints of hives and of the involved forearm, fatigue. So now, begin to pick those risk factor symptoms and signs that can form either red flag or yellow flag for this system. I think it's urogenital, isn't it? No, hepatic. Bear with me. I don't know what's happening to my brain today. I think for the past few days, I've been doing this. Yesterday, all through the day, I had this workshop until the evening. And then in the night, we had train the trainers. And this morning, just coming out. So beginning to have a little confusion. So the surgery took place in another state, and the man who had been a client in our facility before surgery returned for post-operative rehabilitation. Complaints of the involved forearm, fatigue, depression. Now begin to pick them. Fatigue, depression, increased perspiration were documented, but attributed by his physician to recovery from the traumatic injury and the multiple operations. So can you see where our coming in to get this information is important? Because the physician is attributing all these symptoms to something else that is just recovery from the traumatic injury. And it is very possible that these are the key to finding another reason to have a diagnosis that is organic in nature, which the physician was supposed to do. But he attributed it just to recovery and did not really take time to attribute it to what it really is as an organic pathology. Eventually, the client developed a yellowing of the sclerae, white outer coat of the eyeballs. Medical referral was requested, and the client was evaluated by an internal medicine specialist. Hepatitis C was diagnosed. Hepatitis C was diagnosed. So if you go back, the key will be here. Those things that the physician said were attributed to recovery, fatigue, depression, increased perspiration, and all that. I think in one of those slides we said increased sweating in the back, and this and that will form. So these are all symptoms, signs, risk factors that can be used for the evaluation. So hepatitis C was diagnosed, and full medical records then obtained revealed that although the man had donated his own blood in advance for the surgery, he was short by 1 unit, which he received through a blood bank. The blood donation was attributed as the probable source of contamination. Continued physical therapy intervention was modified to accommodate liver impairment, with particular attention paid to activity level. The therapist also observed the client carefully for signs of fluid shift, such as weight gain and orthostasis, dehydration, pneumonia, and vascular problems. We have a lot really to do in our practice to be able to upgrade. Depression is a psychosocial factor, yellow flag. Okay, you need the rest. Okay, don't worry, I will rest after this program because I don't have anything tomorrow. So this is hepatitis. So let's see if there is any other. So this okay, that's hepatitis C. Oh, is it hepatitis? Yes, hepatitis C for this. So symptoms of hepatitis B, the clinical signs are jaundice, arthralgia, rash, dark urine, anorexia, nausea, painful abdominal bloating, fever. This is the way to go. Let's learn these things. Let's remember them. Let's assess them in patients. We'll find out that we are at the top of our game. Go to ward rounds. They say this is a case that should be referred to the authority. I say, I don't think it should be referred to physical therapy. I say, the consultant is asking, why? I say, no, because look at your report. He has reported. He mentioned jaundice, he mentioned rash, he mentioned urine, he mentioned this, he mentioned that. This is a case that should be, of course, many of this, they will, if they are they clearly come out with all this, they should be able to know. But sometimes it's not all of this that will come out. Maybe sometimes they didn't even assess one or two that could have give a clue. I will just say that, well, I think before the referral, why don't you do more assessments? Then there was, okay, like what assessment? Say, have you looked at the color of the urine? Have you looked at if there is this? And then at the end of the day, it will be done. I say, this is not even a case of referral. It's an organic pathology. Let's keep. But believe me, if we don't know all these things, there is no way we can be able to contribute anything. So number one, know them. Number two, know how to assess them and know that they are there. Because you can know it is always theoretical. You go, patient is given to you, you don't even know how to find out if those things are there. Very, very important. Clinical signs and symptoms, chronic active hepatitis. So let's see if there is any other case report. So cirrhosis. So this book can give you both the symptom signs and also show you how to assess them, and then give you, most importantly, the evaluation. When do we say there is a case for referral? Portal hypertension. Can you see all those are risk factors, symptoms, and signs? Case example. So this is a case of example of ascites. A 69-year-old man was seen at the Veterans Administration Hospital outpatient physical therapy department following a left total hip replacement. And you see, mostly it is a musculoskeletal problem. And this is because if you replace the hip, it is a musculoskeletal problem. But it is through systems review that you are not able to identify that there is another problem apart from the musculoskeletal problem that you are treating. And that is why I said you keep. This person, you realize that he has ascites. Will you stop treating the total hip replacement case and refer? No. You will keep that, continue to treat, but then you refer the patient to go and get treatment for the organic pathology that comes from the ascites. So following a left total hip replacement, the surgery was performed at a civilian hospital, but all his follow-up care has been through the VA. That is the Veterans Administration. He had a long history of alcohol and tobacco use. Very important, take note of this. And medical intervention for heart disease. So past medical history of heart disease, alcohol, and tobacco. The only thing is that we don't know how the extent of alcohol take and tobacco, but they say long history of this. So we still need a little bit more information about the extent of alcohol and tobacco intake. So medical history of heart disease, hypertension, and peripheral vascular disease. Take note of all this. The medical problem list established by the physician included liver cirrhosis secondary to alcoholism, ascites secondary to portal hypertension, coronary artery disease with hypertension, peripheral vascular disease, which is arterial, mild vision loss secondary to muscular degeneration. The client was referred to physical therapy for rehabilitation following his total hip replacement. Okay, I have a case I want to share with you, sir. Wonderful. Please, let me just finish reading this, and then I will listen to that. I would really love to hear more of your experiences, your concerns. I think I would really want to have that discussion. The platform is really very quiet, and I think we need to make it more lively. So during the examination, the client reported various other musculoskeletal aches and pains, including chronic low back pain present off and on for the last 6 months, and new onset of groin pain on the left side, just since the total hip replacement. Ascites can be a cause of low back pain and or groin pain. Remember, we showed the areas where GIT can refer pain to. How do you screen this client for a medical, vascular, liver cause of the groin pain? So past medical history, past history of cancer of any kind. Past history of abdominal or inguinal hernia, clinical presentation. Ask additional questions about pain pattern as discussed in chapter 3. There is a chapter on pain. So those different types of pain, throbbing, shooting, what have you, types of pain, they are there. And as I've said, they help you to be able to identify what source of the problem is from the type of pain that you have. What do you think is causing your growing pain? Watch for red flags associated with possible vascular involvement. Client describes pain as throbbing. So can you see? The throbbing pain usually comes from vascular involvement. Understanding the type of pain will help you to be able to identify what the source might be. Pain is worse 5 to 10 minutes after the start of activity, involving the lower extremities, are relieved by rest. So can you see they are trying to bring out intermittent claudication when the case is total hip replacement and the case of ascites, GIT. But they are trying to bring out a case of cardiovascular. So tell me if a patient will not be happy. Of course, they will be concerned that you are telling them they have 2 or 3 conditions. But if truly a patient understands that they can have multiple problems, and the best thing is for those that have not reached a stage that they need hospitalization, if they are identified and treated so that the hospitalization will not be for 2 or 3 conditions, they will be better off. They will feel happier. But of course, it's natural. Some patients, they don't even want to bring out a problem. They'll say, no. This doctor is just trying to bring problem for me. But it is that education that is going to help him to understand that he's better off at that early stage that he gets to know the problem than when it has already developed symptoms that may not be managed. Very important. So this patient has total hip replacement. Part of what the doctor has identified himself are hepatic and biliary problems. But this is the physiotherapist now trying to see some red flags for a vascular problem, a cardiovascular problem. So pain is worse 5 to 10 minutes after the start of activity, involving the lower extremities and relieved by rest, which is intermittent claudication. Visual inspection and palpation, including observing for postural components. Example, lumbar lordosis associated with ascites. So this is a long one. So I'm going to leave you to go through. But at least what we have brought out is the fact that apart from the total hip replacement, there is hepatic and biliary system problem. The physician identified that. And what we are seeing towards the end of this particular section is that the physiotherapist, because that's what they're asking, ask a physiotherapist, what other assessment will you do to bring out something? I say, I've seen possibilities that there might be intermittent claudication. So if you go through, you'll see other things that they did to confirm that as a red flag, to refer or not to refer. Very important. So yes, we have Kate, please unmute and speak.
Okay, good morning, sir.
Yes.
I actually have an interesting case I wanted to share with us. It all started since last week when we had the first discussion that we couldn't finish. I went back to the ward. I had a referral for the patient, about 45-year-old female, referred for, was admitted in our inpatient, in the ward for inpatient physiotherapy. I got a referral. I got a consult that shows that this patient had weakness of both limbs. They were questioning paraplegia. So when I came and I assessed, I noticed from what we were taught, I tried to use the after template, but it was so much anyway. But I tried using it. I started with asking questions to find out based on what I have in the template. I didn't ask the woman what the presenting complaint actually was. So I discovered that this woman doesn't have a low back pain. But then when I asked some certain question, looking at the age, I noticed that she was pre-menopausal woman. She also confirmed to me that she's been taking alcohol for some time. There was not smoking. I asked if I look at the cardiovascular parameters. I discovered that the BP was very high, even the pulse. There was even some level of fast breathing. I listened to the chest, but I couldn't notice anything. So I noticed that, and I asked her if there is a family history of hypertension, and she said yes, her mother was hypertensive. Then I noted that this woman is hypertensive till it was not recently diagnosed that she had a BP. In fact, almost about 200 or something.
Wow.
So recently diagnosed. Now, another interesting thing there is that she's been taking alcohol for but recently I've stopped. It's not like 1 year plus when she stopped taking alcohol. But one fascinating thing that I keep wondering now is that when we look at I try to look at the obstetric and gynecology history. I noticed that the abdomen was big, it was firm. So at that point, I became so skeptical. So I now asked her if she had done an ultrasound scan before. She was trying to hide something. I said, Madam, please, that's the only way I can help you. So on my own, I asked that a scan be carried out on her. So when I was trading that part, because you come and you document something, I now discovered that the team managing was also interested in what I was asking. So we agreed when I spoke with them, like, let us do a USS scan. And we did that, and we discovered that this woman has a leiomyoma that is almost about 40 weeks.
Wow.
The pregnant size of about 40 weeks. So the thing has been there for quite a long time. On that level, I said, okay, because I did my provocative test. In fact, she was not having a low back pain issue. So I know it was then it occurred to me that it could be a spinal cord obstruction. There is something obstructing the spine. So, for me to clarify things, since I'm working with other teams, they now asked her to go and do an MRI, and it was established in the MRI.
Wonderful.
I started managing. They placed her on antihypertensive, and the BP is coming down now.
Wonderful.
Now I said on the physiotherapy aspect of it, she can't walk. I did some neurological examination. I discovered that the reflexes, hyporeflexia. Okay. The muscle power there was virtually like 1, but more on the right. So all the systems, I discovered that there was a cardiovascular issue, even the GIM, not the GIT, obstetric issue, gynecological issues, then the neurological issue. On this neurological issue, in fact, yes, I see also discovered that this woman was diabetic, because I kept looking at the blood sugar. I now opened the chart for myself. I was following the chart. In the morning, I asked her, what was your blood sugar? She said, I don't know. She was not even interested. So I started putting the record for myself to know. So I discovered she was diabetic. I called the medical internal medicine people on and said, okay, they said it escaped their memory. So they placed her on insulin, and gradually the thing is now coming down. Wow. But now my problem is we've started physical our treatment for her, because now we've established that there is a case of obstruction. But now we discovered the muscles are not wasting, because we started early as strengthening exercise and at the same time stimulation, electrical muscle stimulation. But now there are not, we don't have appreciable power on that leg, and I don't know how far we will go to achieve our aim. I was asking what other things, when I invited the other team to discuss the issue, is it a surgery case? That's the point where I'm getting confused. I was thinking that probably they would have gone to do, maybe remove the myeloma, since she's still premenopausal, and that's the risk factor, the age in premenopausal woman. So that's how I came to this, that my own diagnosis. Though for myself, I now said, okay, are they going to do, because it looked like what I'm doing is not effective. but I know the woman is effective anyway because is gaining muscle power. But at what point now do I need to ambulate her? Because the whatever the obstruction is too much, and they are saying they will not do anything for her except she start walking. And I don't know when I'll achieve the walking with the massive fibroid there. So I need,
wonderful.
I don't know, I need you to
wonderful. This
make
is
an
a
input.
wonderful one. Yes, very motivating, really. To know that people will be putting those things into practice to solve problems, because that's all the purpose of what everyone is doing. Wonderful. I'm very impressed. I'm happy that those things have happened and you are able to identify a problem and be able to get a solution to it. Now, with regards to this issue of when should you ambulate, remember, I don't know if you attended the evidence-based practice workshop. We said there are 6 components of patient management, but 5 usually are the ones that in the hospital. You have examination, you have evaluation. Today we have done a lot of discussions on examination and evaluation. Then you have diagnosis, and that is what we are trying now to establish. Either we make the diagnosis or another professional will refer, because we have seen red flag for organic pathology, will refer. You have done all that. But now what you have not done possibly is the issue of prognosis. Now with prognosis, you can also do evidence-based practice for prognosis. What you'll do is that right now you have seen a problem and you have asked a question. Now take that question and do those processes that we did in evidence-based practice. That's the pathology that you are talking about. What recovery is it that you are looking for? Is the issue of ambulation. When will you ambulate the patient? If there is any other keyword, what condition did this? What you talked about compression, isn't it? So those things are the keywords that you will pick. You will now combine them. If there are any synonyms for those words that you have used in the question, you will now have the synonyms. Then you will come up with a search strategy. You will now go onto databases and you do the search. You will now get articles. And you add prognosis. So you're adding the condition, ambulation, and prognosis. You do the search. Articles will come on prognosis that show for patients that have that condition, when do they get ambulated? And then within the articles, you are going to see different characteristics that the papers have used. Then you look at which one is applicable to your patient that has similar characteristics with your patient. And then you will now pick that article, you will read, and you'll be able to see from the results section how long it took, given what interventions for that particular patient that has similar characteristics to yours, to be able to get to the point of ambulation. So this is important. And as I've said, I'm always on that platform. You can always, anyone that has this kind of issues, that does the search, get the article. If they're having trouble getting the article or reading it and extracting what will help their patient, feel free to either post on the group or send it to me using my personal number, because I've been posting there. You see my number, send it to me or send it on the platform so that others also can benefit from it. But this is a wonderful thing. But I believe the way you are going to solve that case, because I can't give you a lot of information because I have not seen the whole clinical picture, and it is something that will need a search of the current evidence that will be best applied to that patient. So my advice is prognosis. Go and do a search of the literature to get articles, then extract, and then go back to the patient and apply. If you need help, I'm always there. Just feel free to send a message on the group platform or on my personal WhatsApp, whichever. That's wonderful. Well done. I saw Mutiet raising her hand, but before that, I saw a message, Adetayo Adefe, that says, but sir, you said we should refer when we suggest a red flag. In case of this patient with ascites, you said we should refer and not pause the treatment. No, I said you can refer and keep. And I think it's difficult for me to explain that because you are doing 2 things at the same time, simultaneously. Now, this patient had a complete, what do they call it? Total hip replacement, meaning they need physiotherapy for rehabilitation after surgery. Now, just because the patient has ascites or that the patient has intermittent claudication or whatever it is that you need to refer that is an organic pathology, it does not stop you from treating
Innocent, read your book.
the total hip replacement complications or whatever it is that comes after the surgery. So in this particular case, you have two cases. You have a movement dysfunction case. You also have an organic pathology. The two exist in that patient. So you continue to treat the movement dysfunction, but you are referring the patient to get care for the organic pathology. So it doesn't mean you refer and you leave the total hip replacement complication. But at the same time, it doesn't mean that you should not refer at the organic pathology problem because you are keeping the patient. So you do both simultaneously. I'm going to continue to see you. I'm going to see you on Thursday. But please, before that Thursday, I want you to go and see a physician and give them this referral case that I've given you. Please, come back on Thursday because I'm going to continue to see you with regards to this particular surgery that you have had. The two are independent. You can be doing that while I'm doing this. I think that's the way to go. But if you have another case that there is no movement dysfunction, it is only organic pathology, those referred, keep the patient. If you have only a movement dysfunction, you don't have organic pathology, you don't refer, you just keep the patient. So these are the three different decisions that you can take. Keep, refer, or keep and refer at the same time simultaneously. Yes, thank you. So is there any comment, any question? Because if we don't have any, we'll be going on break. So I assume this is 12:30 and we'll take 1 hour and we'll come back by 1. Okay, Joshua Imoru, well done. See you. We are always on these trainings all through. We were together yesterday in the morning, afternoon, and evening. So well done too.
Thank you. Thank you,
So
Prof.
go ahead, please.
Thank you very much. I want to commend your effort and your commitments. To the case the lady talked about, and you have actually answered the right way. She should go to do a search to look out for the best evidence concerning the prognosis. And I just want to add to it that when she is doing that, she should also know that whatever evidence she is going to use in form of the prognosis, she should also notice that our own intervention and the modalities that she is using must be the same with the modalities that the article that she already the research she wants to use to for our own patient now, that there must be similarity between the modalities. Because if she just saw something on prognosis and she pick it like that without investigating what modalities, what was the methodology that they use before they arrive at that prognosis. If there is difference between that, she might be having problem at the end of the day when she made a prognosis and she's not getting the expected result. So I just want to highlight that aspect also, that the modalities in use must also be similar. Thank you.
Thank you very much. Very wonderful, very true. Because but number one, papers on prognosis may not really have intervention there, but it may have. But you can have RCTs that have the interventions. But what you are saying, very true. So if a particular paper shows that with so characteristics of a patient, severity of the condition, the age, and maybe other underlying diseases, if you give this intervention over 6 months, you are going to have recovery, or you are going to have the patient being able to ambulate. So those interventions that paper gave, you now come and you see that paper says over 6 months, you can have the ability to ambulate using these particular interventions. But you now give a different intervention and you are expecting to see recovery in the next 6 months. That may not be happening. So meaning the intervention that you want to give, you need to get a paper that has used that intervention and they saw that recovery over a particular period before you set your prognosis to be that period, which is 6 months or whatever. I think that's what he was trying to say, and I think it makes a lot of sense because different interventions may give different effects. You can have one intervention, it will take you 6 months before you get improvement. You can have another intervention, it may take you 3 months to get improvement. And therefore, if you see a paper that uses one and gets an improvement in 6 months, then if you use the other intervention, don't expect to see 6 months for your own recovery or for a patient's own recovery. So I think it makes a lot of sense. We need just to be considering all these things while we are doing the search and the evidence-based practice activities. That's wonderful. So someone is saying we should come back by 2. What is the general consensus? Do we come back by 1:30 or 2? If we are coming back by 2, that would mean 1.5 hours. Is that all right by everyone? Do we come back by 2? 2 p.m. Okay. So that's fine. At least I can see 2. So it's all right. We'll come back by 2 then. Okay, 2 p.m. Wonderful, 2 p.m. That's okay. So, oh, that's wonderful. So that it's done, 2 p.m. So we'll be back by 2 p.m. Thank you very much. And we'll see in the next 1.5 hours.
Oye, I was taught to make bananas to do that. Bananas. Yeah, bananas. But we have bananas. This one is special. I don't know it here, but I need someone to help me bring this down. I'm coming. This is the final area. What do you want to do? See my mom. You will compete. I feel nothing for her. You are not married to your brother. Someday you'll be married.
You are all welcome to the second part of today's workshop. We're going to go straight to the case examples. I think we looked at the urological system, but we have not looked at case examples. So we'll look at that and then we'll go back to the slides. So I've shared the textbook, Differential Diagnosis by Goodman. The first that we have as case example under the urological system is a case of possibly, can someone help read it out, please? Let's just have a little interaction. Let someone also be part of this. Just can someone raise your hand or just unmute and help us read it out? Okay, yes, eBay Precious. Please unmute and just let me know when you want me to scroll up or down.
All right, sir. Thank you, sir. Good day, everyone. Okay, a 66-year-old African American woman with a personal history of systemic lupus erythematosus lost her balance and fell off the deck at her home. She sustained vertebral and rib fractures at T10 and T11. She's a retired paint factory worker. She reported daily exposure to paint and paint solvents during her 15 years of employment. She was seen as a walk-in at the local medical clinic where she's a regular patient. She did not see the rheumatologist who was managing her SLE. The attending physician told her the injuries were probably from the long-term use of prednisolone. Should this be prednisolone? For her lupus. Prednisone, okay, for her lupus. She was referred to physical therapy by the attending physician for postural exercises. During the interview, when asked, "Are you having any symptoms of any kind anywhere else in your body?" the client admitted to a pink color to her urine and some burning during urination. These symptoms have been present since the day after the fall 3 weeks ago. There were no other signs or symptoms reported. Blood pressure measured 175/95 on 3 separate occasions. The client reported her blood pressure was elevated at the time of her visit to the doctor, but she thought it was caused by the stress of the fall. Question: as you step back and conduct a review of systems, what are the red flags to suggest medical referral is needed? To whom do you refer this client?
Good, thank you very much. So please, can we look at the question? The answer is down there, but before we get to the answer from the textbook, can we study the case and answer these questions? So what are the red flags? And then to whom do you refer this client? So either unmute and speak, raise your hand, or we'll call you to unmute and speak, or you post on the chat forum. Okay, past medical history of occupational exposure to paint. Good. So that's one of the things that we're looking for. Okay, any other red flags? I don't know if I do this, if you can see it so that you will see the whole thing, but it might look too small. Okay, so I just hope that you can see the whole thing. Change in urine color, good. Ventricular hypertension, pink color in her urine. Yes, very true. Elevated BP, yeah. So remember, to form a red flag, usually it's a combination. So unless those issues that we discussed, having blood in the urine, blood in vomit, fainting, these are some of the ones that only one symptom or sign can lead to can be a red flag. So burning sensation during voiding, yes, all this are very important risk factor symptoms and signs to consider. Okay, so can we let's look at what is there in the textbook. So can Can you continue reading? Is it eBay, right?
Yes, sir. Okay.
Yes. Okay. Please continue. Can you read as small as it is here, or should I expand? Should I make it bigger?
I have to expand from here.
I should expand?
No, I can expand from here. It's okay for me.
Okay. Okay, let's just make it this big so that everyone can be able to see. Yes, so go ahead.
Age over 40 years, that means age over 50 years is the risk factor for kidney disease. African American descent, that is at risk for diabetes, mellitus, and kidney disease. Long-term use of non-steroidal anti-inflammatory drugs. Elevated blood pressure, change in color and pattern of urine. The therapist do not recognize specific factors present that put the patient as increased risk for kidney disease. For the obvious changes in urine color and pattern along with symptom review, require medical referral. Without the medical records, it is impossible to know what testing was done related to kidney function at the time of the initial injury. The phone call to the referring physician is probably the best place to start. Documentation of the recent events and current red flag symptoms will be sent to the referring physician, the primary care physician, and the hematologist. Physical therapy intervention still autopsy, giving house to skeletal injury. Further medical assessment is warranted based on the development of symptoms unknown to the referring physician.
Yes, thank you very much. That's wonderful. Now, there are just few issues that I want to add on this. Number one, the place where it says during the interview, when asked, are you having any symptoms of any kind anywhere else in your body? This is a very important question. Whenever you are assessing patients, no matter how much of assessments you do, at some point in time, you need to ask the patient, are you having any symptoms of any kind anywhere else in your body that we have not discussed, that I have not asked you, or that you have not reported? If you look at this particular situation, that is what brought out this issue of urine, that now gave a clue as to the fact that there may be a urological problem. Because what the patient reported with was SLE that was there in the past, and then the fracture at T10 and T11. But the physiotherapist, because of this particular question, was able to get information from the patient that helped with a referral and the possibility of diagnosis in the urological system. This is a very important question to ask. Another thing that is worth noting is the way the referral and the interaction with the physician was. Documentation of the recent events and current red flag symptoms should be sent to the referring physician, the primary care physician, and the rheumatologist. So can you see what we were talking about earlier? They were not saying this is what the diagnosis is, or this is what the physician should do, just that documentation of the recent events and the current red flag symptoms. So it is those red flag symptoms that they documented and they sent to the physician and the rheumatologist and the primary care physician. So it is important when you are making the referral, if the patient is seeing a physician and a rheumatologist and possibly a cardiologist, in as much as those symptoms are related to those areas that they are seeing or that can influence them, or the drugs that they take can, whatever it is, if there is a relationship, there needs to be referral sent to those other healthcare professionals that are seeing the patient. That is what this is saying as to who should refer. And look at this, it's even explaining how each of them is either a risk factor or a symptom of the disease. Very specific, given the age, the race, and the drugs they're taking, the blood pressure, and the color of the urination. And it is these things put together that forms a red flag. And that's what I was saying earlier. The red flags the red flag comes because of the combinations. So if just because the patient is 60 years, it's not a red flag. That's just a yellow flag. African American, is that a red flag? No, it is a yellow flag. But put together with the issue of change in color, which is a symptom, that's what makes the physiotherapist to make the referral. So that's a very good one. There's another one about bladder infection. But I think we have taken one. Let's just go and see other systems of the body. Let me just scroll down and see if what we have is endocrine system. There's another one on prostate cancer. So very important, since you now have the documents. This is one of the textbooks posted on the platform, WhatsApp platform. You can go through the remaining case studies that are there. So there are testicular cancer and others. Just want to scroll to endocrine so that when we come back, we'll just look at it. Yes, screening for endocrine and metabolic diseases. Okay, so endocrine, what are the red flags? Confusion, lethargic, so the patient feels they don't have energy. Changes in mental function, we have discussed this earlier. The issue of memory, people can't remember things, they can't comprehend things, they can't do information processing, their attention is low. All these are changes in mental function. So profuse sweating. Signs of ketoacidosis. So what is ketoacidosis? Fruity smelling mouth, so nausea, vomiting, deep breathing, etc. So all this suspect hypoglycemia. So hypoglycemia, that's in people that have diabetes. So if you have all this, it's an endocrine system problem, and it's a red flag. It's a red flag. And I think each and every one of them is something that we can be able to assess, to be able to see if someone is confused, if they have less energy, possibly they will report that. They feel as if all the energy has been driven away from them. Changes in mental function, the patient's attention, as we are discussing with them, questions about whether they can remember things, if they can be able to know what's happening around them, if they can be able to follow instructions, 2 instructions at a time. So they do this one, they now follow with the other one. This is about information processing. Sweating, we can be able to either see it or get to know it from the history. And then signs of ketoacidosis, either the patient says they feel it's a smelly, fruit-smelling mouth, or the relatives feel that, or you that is speaking to the patient feels that. They can report having to feel like they are going to vomit, and possibly they vomit there, or the relatives reports that they have vomited, or they report that they have vomited. Deep breathing, that can be seen or reported in the history. Then signs of potassium depletion in patients using non-potassium sparing diuretics. So usually these signs of potassium depletion are muscle weakness, so they have muscle weakness or cramping, fatigue, cardiac arrhythmias, so the breathing pattern is abnormal. They have nausea, vomiting, dehydration. So this also is a red flag. Then signs of thyroid storm, so tachycardia, the number of cycles of the heart beat has increased. Elevated core body temperature. It's important to get this. It's not the surface body temperature, but the core body temperature. So so for example, if you are using the rectal procedure for taking body temperature, you can be able to get the core temperature. So elevated core temperature, restlessness, agitation, abdominal pain, nausea, vomiting. You can see nausea and vomiting is appearing in many systems of the body. So usually if there is organic pathology, there's that tendency to have nausea or vomiting. But it can be across different systems of the body. But what is important is to look at the other symptoms that are attached to it. If there are symptoms, for example, fainting, and then it's neuro. We have talked about cardiovascular and pulmonary. We have also talked about urological. So this is under endocrine. What comes with it more of elevated core body temperature, restlessness, agitation that we have not seen in the others as a combination like this. So this is for endocrine disease. Diabetic coma, red flag. Yeah, yes. So unexplained fever. So it's no, they have done a test for malaria, they have done a test for typhoid. So well, they are all infections too, but we are looking at the endocrine system. So if you want to link it to endocrine system, it's not explained, and they are taking corticosteroids, then this is related to the endocrine disease. Then palpable nodules. It's important to learn how to palpate the nodules. It's important to find out the locations where the nodules are and how do you palpate them. What is the difference between a nodule that is normal and a nodule that is palpable? So that's important for us to do. So palpable nodules in supraclavicular area. That's the scalene triangle. New onset hoarseness. So there was no hoarseness before. The patient now has hoarseness when they have blood in their when they spit. There's blood, increase in blood pressure, and then the palpable nodules. All these put together, they are a red flag for endocrine disease. Multiple eruptive xanthoma. So this in the skin is a skin condition caused by high lipid in the blood. On extensor tendons of patients with diabetes, uncontrolled glycemia. I think it will be important just to look at the way it is in the skin. Usually the pictures are important. So multiple eruptive xanthomas. This is how it looks. So multiple eruptive xanthomas, different ways that they can be seen. So it's important when you see this kind of skin conditions in patients that comes together with those other symptoms. Yes. So the extensor tendons of patients with diabetes. So they are uncontrolled glycemia. So they already have the diabetes, but you see the multiple eruptive xanthoma. So if they have diabetes, they are on their drugs, it's controlled, that's fine. You don't need a referral because they are already, but whenever you see the multiple eruptive xanthomas and they have diagnosis of diabetes, then it means suspect uncontrolled glycemia. There's glycemia that is not controlled, and therefore it's an emergency case you refer. Signs of fluid loss or dehydration. So dehydration in patients on diuretics. So they're on diuretics, but they have signs of fluid loss or dehydration. So it's dry, they feel thirsty, very much thirsty, and a number of other symptoms that show dehydration. So this shows that possibly pituitary gland releases vasopressin to influence kidneys to conserve the water. So this is a case of referral to recurrent arthritic symptoms in a patient with gout taking urate lowering drugs. So they are urate lowering drugs, but they have recurrent arthritic symptoms. That's a red flag under endocrine system. So what are the yellow flags? Past medical history of endocrine or metabolic disease. So anyone that has reported in the past medical history of endocrine or metabolic disease, this is a yellow flag for endocrine disease. Bilateral carpal tunnel syndrome. So they have carpal tunnel syndrome. Proximal muscle weakness. Proximal. So proximal muscle weakness. Carpal tunnel syndrome. Shoulder periarthritis. So all this put together, yellow flag for endocrine system. And these are all things that we can be able to do our assessments. We assess muscle power in the up. We see that the upper muscles of the arm, the upper limb, are weak. There's shoulder periarthritis, and there's also bilateral carpal tunnel syndrome. We suspect that there may be an endocrine disease. Long-term use of corticosteroids. So patients report that they have been taking corticosteroids for a long time. They may be exposed to Cushing's syndrome. That's excess cortisol. Very important to continue to monitor them. Trigger points not relieved by therapy. We have mentioned this before. So this is likely hypothyroidism. So metabolic alkalosis, lack of chloride. So muscle fasciculation, we have also discussed fasciculation the other time, and cramping. So muscle weakness and fatigue in patients that are on diuretics. So the patient has reported being on diuretics, and that is why it's important to have that drug history. What drugs do the patients take? I think in these few slides on endocrine, we have seen a number of issues with taking corticosteroids, with taking diuretics, and other drugs that we have seen in the other slide. So very important to take the drug history, because the drug history, either because of taking it, the side effects can lead to risk of having other diseases, or possibly because two drugs interact to form an interaction effect. And that interaction effect might be the risk, what put the patient at risk of having another condition. So you have arthralgias, hand pain, and muscle weakness. This also are yellow flags. So let's just go back to that textbook and look at the questions that we can ask on the endocrine system. Oh, no, not this one. Okay, oh, it's the one that I shared already. Okay, so it's here. So under endocrine system, have you noticed any swelling in your neck? Do your hands tremble? Do you prefer hot or cold weather? Have you had a thyroid problem or diabetes? So these are past medical histories. Have you noticed increased sweating? Have you been troubled by fatigue? I think these are some of the few signs or symptoms that we saw under the red flag. Have you noticed any change in your appearance, hair, skin, or voice? Have you been usually thirsty lately? New onset of diabetes. So these are just some of the questions that we ask to patients. So let's look at some case reports. Yes, so screening for endocrine and metabolic disease. So these are some of the clinical features: polyuria, nocturia, polydipsia, dehydration, decreased urine-specific gravity, fatigue, irritability, increased serum sodium. So you're going to see those in many different conditions: acromegaly, adrenal insufficiency, Cushing's syndrome. So this is a case example. Yes. So can another person help us read the case example? If they read the other one, can we have another person read this? Any volunteer? Yes, Josefa.
Good afternoon, Prof. The question says, a 53-year-old woman with Cushing's syndrome resulting from long-term use of cortisol for systemic lupus erythematosus reports the following problems: hair and nail thinning and breaking easily, temperature intolerance, always cold, muscle cramps, generalized weakness, and fatigue. Her primary complaint and reason for referral to physical therapy is for SI joint pain as a result of stepping down off of on an even curb. You realize the signs and symptoms are of an endocrine origin, but you do not know whether they are part of the Cushing syndrome or a separate endocrine problem. So should you send this client to a physician or back to the referring physician?
Yes, thank you very much. So can we attempt, what are there red flags or are there just yellow flags? And I think this is what they're trying to bring out. So if you think that it might be just a symptom that is part of the SIJ problem, so you realize the signs and symptoms are of an endocrine origin, but you do not know whether they are a part of the Cushing syndrome because she already has been reported to have Cushing syndrome or a separate endocrine problem. Do you think from what has been presented, there is any red flag for another a separate endocrine problem apart from Cushing syndrome? Is there any? Is there a need for referral so that if it is not the Cushing syndrome that brought about this, that there will be need for another diagnosis? Yes, I can see a message. Okay, yellow flag. Okay, so yellow flag. Any other comment? Why do you think it's a yellow flag? Or any other comment if there's any? Okay, no other comment? Okay, so Josefa, let's see if the answer is there. The question is there. Let's continue. Potassium deficiency, cramps, generalized weakness. Okay, so is that yellow flag or red flag? Because a yellow flag, you keep the patient and continue to monitor and assess until you see a red flag. So generalized weakness and fatigue is a yellow flag. Okay, yellow flag. It's like almost everyone is thinking it's a yellow flag. So if at the end they say we should refer, then there is reason to believe there is a red flag. But possibly if it is just consultation, it's still yellow flag. If you keep the patient, it's still a yellow flag. So all the listed signs and symptoms are endocrine system issues. Itself is a yellow flag. Okay, red flag. So let's just see. Josefa, please, can you read through? Okay, Josefa is not there possibly. So let me just read through. It says not necessarily. So that means yellow flag, just like many have been saying from the look of it. But let's read through and see what is the justification. This is more a case of a need for additional information. Okay, so that's confirming that it's a yellow flag. Requesting a copy of the client's most recent physician notes may answer all of your questions. So can you see that it is possible? If you don't have enough information that comes with the referral, you can ask for more information. You can ask to go and see the file. You can ask for the file to be brought to you. You can ask for the physician to give more details. You can even point the areas where you need more details that will help you to be able to make a decision. So reading the physician systems review portion of the examination may reveal a record of these signs and symptoms with a corresponding medical problem list and plan. If there is no mention of any of these associated signs and symptoms, a phone call to the physician's office may be the next step. If you speak with the physician directly, identify yourself and your connection with the client by name. Briefly mention why you are seeing this client and make the following observation. Good. So I'm going to see example of what you do in a case of consultation. So this is a case of consultation. I've been mentioning this. I said refer, keep and refer and consult. So Mrs. Jones reports muscle cramps and generalized weakness that do not seem consistent with her SI problem. Okay, that's what I was telling you, that I'm going to get a format. I've been trying to put it in this way and I was having difficulty. I was just giving general statements, but this really looks good to say that those symptoms and signs or risk factors that are yellow flags, that's if it is consultation. But if it is red flag, then you have the risk factors, symptoms, and signs that are the red flag. You now state them say that they do not seem consistent with the diagnosis that was referred to you. And that is all right to do that. Even though these are different cultures, the physicians there, you can write something like this to them and send it. They might feel okay. The ones here might not feel okay. It all depends on traditionally what is acceptable as a language that can go in between professionals where you practice. So do not seem consistent with her SI problem. She complains of temperature. So now you are now adding those things that you think might make it to be something else and not the SI problem that was sent to you. She complains of temperature intolerance and hair and nail bed changes. These symptoms are outside the scope of my practice. Can you see the language? Very straightforward. So the person is going to now take it up because it's possibly within their scope of practice. So, but what are those things that were listed to say it's not within the scope of my practice? These are the issues that look like there is a pathology, an organic pathology. So temperature intolerance, hair and nail bed changes. This definitely look like there is an organic pathology. Can you help me understand this? Are they a part of her lupus erythematosus, Cushing's syndrome, or is this something else? Very good. So very diplomatic, but as I've said, it all depends on your practice and the tradition there. But this is just an example of how you can send that referral or consultation with that one. So this is another one, Hashimoto's thyroiditis. Let's see how, this is a lot. I don't know if we'll have the time to go through something as long as that. So this is another one, Graves' disease, hyperthyroidism. So this one is not too long, especially the case and the question. So can someone help us to read out this? Another volunteer, please. Yes, Edna.
Good afternoon, Prof.
Afternoon.
Good afternoon, all. Graves' disease, a 73-year-old woman who has rheumatoid arthritis, has just joined the physical therapy aquatic program. Despite the climate-controlled facility, she becomes flushed, demonstrates an increased respiratory rate that is inconsistent with her level of exercise, and begins to perspire profusely. She reports muscle cramping in the arms and legs and sudden onset of headache. So the questions are, how would you handle this situation? And can this client resume the aquatic program when her symptoms have resolved?
Yes, so any responses? Any response? How will you handle this situation? Looking at what we have from there. Or any red flags? Any yellow flags? There's a yellow flag. Okay, so can you point out what is there that forms a yellow flag? I don't know who is Hafiz. Please just look at when we were on break, people that snapped the YouTube, the one linked to this, they were also posting, and I saw some interesting things. If there is anything there that someone, maybe the coordinator, that can post on the chat forum here that I can be able to see, because I don't have access to the other one. If there is anything interesting, different from what we are having been posted here, that would be good. Yes, there's a red flag. So what is the red flag? So we have sudden onset of headache. Okay, there's a yellow flag. It says sudden onset of headache. Then there is a red flag. Okay, sudden onset of headache. Yes, I've seen that earlier. Any other thing? Well, now there's no any question there. Okay, wonderful. Thank you. Okay, so maybe since I can't see other responses, Edna, can you read out the results? Okay, sorry, before you read,
Okay,
let's
sir.
see. Increased respiratory rate, red flag. Increased respiratory rate, sudden onset of headache. Okay, so increased respiratory rate, sudden onset of headache. Okay, so let's see what we have there. Yes, go ahead.
The result was the client was quickly escorted from the pool. Her vital signs were taken and recorded for future reference. Later, the therapist reviewed the client's health history and noted that the thyroid medication she reported taking was actually an anti-thyroid medication for Graves' disease. The heat intolerance associated with her Graves' disease, hyperthermia secondary to accelerated metabolic rate, presents a potential contraindication for aquatic or pool therapy. Heat intolerance contributes to exercise intolerance, and the client was exhibiting signs and symptoms of heat stroke, even when exercising in a climate-controlled facility. The physician was notified of the symptoms and how quickly the onset occurred after only 5 minutes of warm-up exercises. Strenuous exercise or a conditioning program should be delayed until symptoms of heat intolerance, tachycardia, or arrhythmias are under medical control.
Wonderful. So can you see the contraindication? But the contraindication comes from what? It's even the drug that she's taking. So this is really to emphasize the importance of the drug history. Very important. It can even serve as contraindication to some other interventions that we can have. Very, very important. So I think from what we saw, it wasn't really a red flag directly, but there was a yellow flag, and they did more investigations. So vital signs, and then ask questions about the drug, and that was when they got to know of the red flag or the contraindication to the aquatic or pool therapy that they were given. So wonderful. That's a good one. So let's go back to the slides. Yes, so let's look at hematological diseases. So what are the red flags? Viral diseases. So this is when you have a past medical history. So the patient has had or is currently having viral diseases or infectious hepatitis, rheumatoid arthritis, liver cirrhosis, autoimmune disease, severe infections, bone marrow failure after chemo or radiation therapy. All this could lead to the suspicion that there may be low leukocyte count, which is leukocytopenia. So leukocytopenia. So part of your past medical history or current medical history, those diagnoses that the patient has, if they have these issues, be suspecting in the same vein, anxiety can trigger it, especially if it is the first inside pull. All right, yes, so these are all differentials, but what they found out in her own case was that drug that she was taking for that particular disease that they mentioned. So when the patient has fever, chills, sweats, sore throat, and cough, suspect leukopenia. That is when the white blood cell count has gone below 5,000 per macroliter or millimeter cube. So that's leukopenia with white blood cells. Then feeling weak or tired, swollen lymph nodes. As I've said earlier, very important to find out the locations of the lymph nodes and how to palpate them. And when you palpate them, what's the difference between what is normal and what is abnormal? These are the things that will help us to be able to collect relevant information that will be used this as evaluation or interpretation. So swelling or discomfort in the abdomen. So there is swelling in the abdomen or there is discomfort. The discomfort the patient will report. Pain in bones or joints, patient will report that they have pain in their joints. But if they feel weak and tired, and you palpate the lymph nodes and they are swollen, discomfort in the abdomen, all this put together, I think of leukemia. So cancer of the blood. So bruising in the skin. See, bruising is coming with many. I think it was there in endocrine. We are seeing it here in hematological. And there's one other system where we saw bruising in the skin, joint, and mucus. Then hematomas. You'll have a little outgrowth, but there is blood underneath the skin, the hematomas. You have swelling, you have petechiae, decrease in number of, okay, so this shows that there may be decrease in, this is the skin condition, the petechiae. Maybe it will be important to have a look at them. Yes. Let's see, it's different from what we had with the pictures that I showed earlier. But it's similar, but it's different. Let me go back so that you see the other one. So this one is not as pronounced as the other one. The other one is, you can see this one's the xanthomas, eruptive xanthomas. And they are more pronounced, more accumulated in the area. So there's a difference between the two. And that's why I showed the pictures, because just describing them or saying their name doesn't help you when a patient comes and he has them. And this is what I'm going to advise you. As you go through the slides, any of the things that is said there that you can't visualize it when a patient presents themselves, just Google it. You'll be able to see it. Or possibly you go to textbooks, best, because Googling is just to understand that concept. But if you want to use it for patients, as I've said, you need to go to a more reliable and acceptable database. But textbooks that show pictures may be better than just Googling it. But usually I use the Google just to understand the concept immediately. But if you want to use it on your patients, I will advise that you go to more reliable sources. So can you see the difference? There's a difference between this. So it's like, it's not as pronounced as the xanthomas. That's this particular one. There's another one, I think, that was mentioned apart from this. What was it? What was it? Swelling, hematomas, bruising, bone joint swelling, discomfort, swelling, lymph nodes. Can you remember which one is it that I saw? Bruising skin joint hematomas. Okay, hematomas. So let's just quickly look at that. Yes. So hematomas. So just in the skin, as if blood accumulates just beneath the skin. Yes. So as I've said, very important to be able to understand how it looks in dark-skinned individuals, because that's what we are going to see more. Yes. So that's thrombocytopenia. It's about platelets when they are less than the normal, less than 150,000 millimeter cube. So because it's hematological, we're looking at low leukocyte count, we're looking at leukopenia, looking at leukemia, looking at thrombocytopenia. So these are what you see that makes it a red flag for hematological diseases, but suspecting even more specific conditions. And all these conditions are organic pathology related. And that is why they require referral. They are all red flags. So we have that for hematological. So let's see some of the questions that we can ask the patients. Okay, so here it is. I just hope we have the hematological. Somewhere I saw hematological earlier. Okay, do you bruise easily? Yes, so we have seen the issue of the skin bruising. Have you had fevers? We have seen fevers and shivers. So these are the questions. Do you have difficulty stopping a small cut from bleeding? So looking at the hematomas, bleeding disorder. Have you noticed any lumps under your arms or in your neck or groin? Hematological malignancy. Have you ever had blood clots in your legs or in the lungs? So this is usually through past medical history that you get that. So these are just few, but I think from the ones that we have listed earlier, those are many that we can also think of how to ask the patients. So let's see if we can get something on the patient a case report. Yes. So I think what we have here is endocrine. I believe what is next should be, okay, let's see. I see there's a comment. You didn't highlight yellow flags. Yes, I missed that, but you can find them in this book. There should be a lot of them. I missed that. I also noticed it, but I didn't have it there on the slides. So maybe as we go through, we might see some of them. So this is a Charcot shoulder neuroarthropathy, but all these are under endocrine. Just trying to see if we have any examples for hematological. Okay, hemochromatosis. Have I passed gout, pseudo gout? Now all of this I think are endocrine. Osteoporosis. Osteoporosis. Oh, this is immunological. So that is, it's not part of my slides, but you can study it from here. Just hope the next one is, or possibly screening for cancer. Okay, what will happen is that, let me just check if I have it in my DPT file. I just posted a picture. What is it? I just posted a picture. Okay, I will check. I've not seen the, well done, sir. Please, can you use big fonts for the writing? It's difficult to see clearly by some of us. So that's the writing on the slides. Just find out if it is the writing on the slides. I understand. I can make it bigger. I think those that are joining through Zoom are not having difficulty. I've not seen any comment on that. So, but I will see how I can make it bigger later. I hope your eyes are not becoming like mine because. Yes, so let me just check the folder. Apologies, because I wasn't prepared really because I didn't know that I was going to online programs. Completed systems review. I'm looking for hematological, right? Hematological. Example. Yes, please just bear with me a little bit. Let me just endocrine. Okay. No, I think we have done endocrine. Yes, hematological. Wonderful. Anemia. Anemia. So can someone help us read, please? Okay, it's just one page. And read this case report on anemia. Okay, maybe the hands are raised. Okay, anyone can? Yes. Okay, Josefa, you have read before, but since you have raised your hand twice, you can read this one. Good. We have 3 people, so we'll have 3 case reports, and each of you, Josefa, Abubakar, Chiamaka, each of you, please. So Josefa, go ahead.
The brief history. A 72-year-old woman, status post-hip fracture, was treated surgically with nails used for the fixation of the ends of fractured bones and was referred to physical therapy for follow-up treatment before hospital discharge. The physician's pre-operative examination and surgical report were unremarkable for physical therapy precautions or contraindications. When the therapists met with the client for the first time, she had already been ambulating alone in her room from the bed to the bathroom and back using a hospital wheeled walker. She was wearing thigh-length support hose, hospital gown, and open-heeled slippers from home. Although the nursing report indicated she was oriented to time and place, she seemed confused and required multiple verbal cues to follow the physical therapist's directions. After
sorry, before you go further, at least
Thank
we
you.
have seen confusion. We have some confusion. And this issue of require multiple verbal cues, it means there is mental status change. So because, yes. So at least let's take note of those things that we have seen in the slides earlier. Thank you. Yes, go ahead.
After ambulating a distance of approximately 50 feet using her wheeled walker and standby assistance from the therapist, the client reported that she could not catch her breath and asked to sit down. She placed her hand over her heart and commented that her heart was fluttering. Blood pressure and pulse measurements were taken and recorded as 145/72 millimeters of mercury and 90 beats per minute pulse rate. The physical therapist consulted with nursing staff immediately regarding this episode and was given the go-ahead to complete the therapy session. The physical therapist documented the episode in the medical record and left a note for the physician, briefly describing the incident and ending with the question, are there any medical contraindications to continuing progressive therapy? Result, a significant fall in hemoglobin often occurs after hip fracture and surgical intervention, secondary to the blood loss caused by the fracture and surgery. Other contributing factors may include blood transfusion and alcoholic liver cirrhosis. In this case, although the physician did not offer a direct reply to the physical therapist, the physician's notes indicated a suspected diagnosis of anemia. Follow-up blood work was ordered and the diagnosis was confirmed. Nursing staff conferred with the physician and the therapist was advised to work within the patient's tolerance using perceived exertion as a guide while monitoring pulse and blood pressure.
If I have some of you seen some abnormal statements there, I'm very sure some of you are. Let me see. It's the 2013 version of Goodman and Snyder. I think the one I was sharing, was it not 2018 or 2016? So usually the practice in the US evolved over autonomy, and the issue of first contact has been evolving. So I'm very sure if we check the current version, that is why I quickly went up to see what version this is, because the other textbook, let me open it. I know this version of the textbook. If I'm to go down, anyway, oh, 6th edition, but what year? I will check later. I don't want to go up and then miss the page where we stopped the screening for cancer. But I know some of you will have questions. I'm just trying. So those abnormal statements about the issues of autonomy. Yes, in this case, it shows the need to include cognitive assessment, exactly, like attention and memory during the history taken. Yes, I agree. Strong. Yes, okay, so let me go back to the document. Okay, or maybe let me share another one. Okay. Okay, just trying to open the one that is more relevant. Sorry, just bear with me. Okay, sickle cell anemia, good. Okay, this one is long, but we can just read part of it because of the time, but it's up to us. Let me see. Yes, I think we had Abubakar and Chiamaka, any of the two that is still available. Okay, Abubakar, please go ahead and read. So this is a sickle cell anemia case.
Okay, sir. So
Okay,
this
yes,
is a
go
case
ahead.
of a 20-year-old African-American woman that came to a physical therapy with severe right knee joint pain. She could recall no traumatic injury, but reported hiking 2 days previously in the Rocky Mountains with her brother, whom she was visiting. She was from New York City. A general screening for systemic illness revealed frequent urination over the past 2 days. She also complained of stomach pain, but she thought this was related to the stress of visiting her family. Past medical history include one other similar episode when she had acute pneumonia at the age of 11 years. She stated that she usually felt fatigue, but thought it was because of her active social life and busy professional career. She is a non-smoker and a social drinker. So she drinks 1 to 3 drinks per week. On examination, the right knee was enlarged and inflamed, with joint range of motion limited by the local swelling. In fact, pain, swelling, and guarded motion in the joint prevented a complete evaluation. Given that restraint, there were no other physical findings, but not all special tests were completed. The neurologic screen was negative. This woman was treated for local joint inflammation, but the combination of change in altitude, fatigue, increased urination, and stomach pains alerted the therapist to the possibility of a systemic process, despite the client's explanation for the fatigue and stomach upset. Because the client was from out of town and did not have a local physician, the therapist telephoned the hospital emergency department for a telephone consultation. It was suggested that a blood sample be obtained for preliminary screening, while the client continued to receive physical therapy. Laboratory results include the following: hematocrit 30%, hemoglobin 30 gram per deciliter, white blood cells is 20 millimeter mercury, 20 millimeter square, sorry. Based on these findings, the client was admitted to the hospitals and diagnosed as having sickle cell anemia. It is likely that the change in altitude, the emotional stress of visiting family, and the physical exertion precipitated a crisis, now referred to as episode. She received continued and was discharged with further follow-up planned.
Home City. Thank you. Thank you very much, Abubakar.
Okay, sir.
I think this is a document, another study or another book. So thank you so much. So at least what the area that is relevant to us, I think is said the client was, okay, sorry. Where was it that I saw those issues? In fact, inflammation or the combination of change in altitude, fatigue, increased urination, and stomach pains. So these are the symptoms that led to alerted the therapists to the possibility of a systemic disease. And these are the issues that we are looking at. So as you are treating the patient, you ask the questions, the patient tell you things, you put them together. This is our evaluation. From all that therapist gathered, he said, well, look, this issue of change in altitude, this patient gets fatigued, increased urination, stomach pains, all this put together, they said, well, there might be a problem with the hematological system. And at the end of the day, see what happens. There is a diagnosis of sickle cell anemia. Or possibly it was even there as he was treating, he didn't know that it was there because possibly the patient was not in crisis and therefore they came, he was just treating. But seeing those things, he asked, and would be told, well, there had been a diagnosis in the first, need to know as therapist. Wonderful. Possibly we can add just one more, maybe. Let me see if there is any example that is not too bulky. I'm not sure why this is here, but let's read it. So Chiamaka, I'll share this. You'll read. I think that will be the last one we'll read from here, and then we'll move on. Yes, Chiamaka, if you are there, please, can you help us read this?
Good afternoon, Prof.
Yes, afternoon.
It's a brief history. At presentation, a 57-year-old man had rib pain that began 1 month ago. He could not think of any possible cause and denied any repetitive motions, recent trauma, forceful coughing, or any history of tobacco use. Past medical history was significant for hepatitis A 10 years ago, and benign prostate hyperplasia, BPH. The BPH is reportedly well controlled with medication, but he noticed a decreased need to urinate and mentioned that he has been meaning to have a recheck of this problem. On examination, there was bilateral point tenderness over the posterior 7th and 8th ribs. Symptoms were not increased by respiratory movement, trunk movement, position, or palpation of the intercostal spaces. Trunk and extremity movements were considered within normal limits, and a neurologic screening examination was unremarkable. The therapist could not account for the client's symptoms, given the history and clinical presentation. Further screening revealed that the client had noticed progressed fatigue and generalized aching over the period of 2 weeks that he attributed to the flu. He had lost about 10 pounds during the week of vomiting and diarrhea. Vital signs were taken and were within normal limits. There were no other red flag symptoms to suggest a systemic origin or symptoms. For the results, without a proper physical therapy diagnosis on which to base treatment, the therapist did not have a clear plan of care. There was no well-defined musculoskeletal problem, but a variety of systemic variables were present. Example, sudden weight loss and constitutional symptoms accounted for by the flu, oliguria attributed to BPH, insidious onset of rib pain. The therapist decided to treat the client for 7 to 10 days and reassess at that time. Intervention consisted of stretching, manual therapy, postural exercises, and Feldenkraris techniques. At the end of the prescribed time, the therapist asked a colleague in the same clinic for a second opinion at no charge to the client. An ultrasound test for possible rib fracture was performed and was considered negative. No new findings were uncovered, and it was agreed collaboratively, including the client, to request a medical evaluation of the problem from the client's family physician. The client was subsequently given a diagnosis of multiple myeloma and was treated medically.
So what do we all think of this case? We are seeing different scenarios, and I've mentioned the different decisions that we can take. What do you think of this case as it differs from other ones that we have looked at? Okay, this one possibly is a mistake. Okay. Okay, what do we think of this case? Any thoughts? Looking at all the ones that we have looked at and those different decisions, 4 different decisions that I talked about, where will you place this? Any thoughts, or is there a hand raised? I'm not looking at. Okay, there's no hand raised. Can someone, anyone, post, speak, unmute and speak? Or are we all tired? Are we all tired? Should we stop if we are not assimilating? Okay, let me say this. In most of the cases that we have seen, the physiotherapist straight ahead was convinced that there was a case made for referral. So the physiotherapist did an evaluation and said, hey, look, these are red flags. We have a red flag. This is a case that needs to be referred. And I know who to refer to. Just refer it. I remember there was a case that I was even saying, you refer to the physician, you refer to the rheumatologist. So you know who to refer to. You know what you are referring. And you write so, but this case, at some point in time, there was no specific issue that's a red flag that the physiotherapist identified as a red flag. Not that the red flag was not there, but the physiotherapist was not able to identify any red flag that he or she was certain that there was need for a referral. So what did they do? Consultation. And it was in the consultation and possibly just open referral. We can't find any red flag. But what we have is not reflecting something that is within the scope of our practice to treat. And therefore, we are referring. We are not giving you any links, any specific thing, just take over. But at least the fact that they were not able to find out what is within the scope of their practice, and they referred, and the case would have been referred to them initially. This diagnosis of multiple myeloma was not made. So what they did as to get different issues and say that, well, we can't see this giving us any result for a referral as a systemic disease. We also can't see this. They have raised questions that were unanswered. That now made the physician to now possibly question the initial diagnosis, and therefore now paved way for another diagnosis, which is multiple myeloma. So this is another good one because it has presented a different case from the ones that we have that had certainty in the case. Yes, so let's go back to the slide. I think we're almost done. So I believe we should be almost done. So just bear with me a little bit. Yes. Okay, integumentary. I think we only have integumentary and then pediatrics, and then that is it. So integumentary system, the red flags, pale white, so the skin looks white, anemia, so lead poisoning, internal bleeding. So whenever the patient looks whitish, and then that's another thing. What do you see when there is pale in dark-skinned people? So anemia. Think of anemia, think of lead poisoning, think of internal bleeding, chronic GIT disease, cancer, parasitic disease. So when you see blue coloration, then it's either cerebrospinal disease, high blood iron level called hemochromatosis, vasomotor instability, which is cutaneous vasodilation, sensation of heat, decrease in core body temperature. Remember, we talked about core body temperature. So not just taking the external body temperature, but the core body temperature. So yellow is when there is liver disease, hepatitis, or jaundice. So when there is arterial insufficiency ulcers, when you do the ankle brachial plexus, I told you the way you take the blood pressure in the arm, so you take it at the ankle. So then what you do is to divide that of the ankle by that of the arm. So if the result is between 0.95 to 1.19, then it's normal, but anything below that is abnormal. So meaning that is arterial insufficiency also. So that's ankle brachial index. So when you see a punched out appearance that is painful, and it occurs more distally because the blood would reach the proximal parts before it gets to the distal part. And therefore, if there is insufficiency, it does not get the chance to get to the distal parts. And therefore, you see such presentations that are seen skin-wise at the distal part. You can also have venous insufficiency. It's not been drained up. So pitting edema, because it's not been drained, there's venous insufficiency. So you'll have pitting edema, fibrosis. So that's the skin looking kind of thick. So possibly I will show that when I go back to the other platform. Warm skin, because the blood is there, it's not been drained. A hemosiderin staining, so blood leaking from the capillaries. So all these are signs that there are venous insufficiency. So these are some of the pictures. Okay, so I don't need to go there. I think I even have the pictures here. Skin ulcers. So for this, we have, so the left arterial insufficiency ulcer, and for the right, venous insufficiency. So that's what was it that I was saying I was going to show you? Fibrosis. Yes, the fibrosis. So these are the skin ulcers. Then rash spreading quickly and accompanied by fever, fatigue, and malaise and joint pain. This shows possibly that there may be skin cancer. When you have brittle hair leading to breakage, possibly suspect hypothyroidism. When you have nail bed appears white for more than 2/3 of the length of the nail, we are going to see the picture. End remains pink. The end remains pink. So this is possibly there is cirrhosis of liver or heart disease. When there is clubbed nail, possibly heart and lung diseases. When there is nail pitting, small punctured depressions, possibly there is psoriasis. When we have transverse white lines, acute illness, heavy metal poisoning, arsenic poisoning, or when there is chemotherapy. So I'm going to show some of the pictures. Yes, so this is the nail pitting. The nail pitting, and this is showing the white lines. This is showing the white lines, and this is the nail pittings. So it's important to see the pictures, because that's what will help you when you see patients and they look like what is in the pictures. Then you begin now to suspect those conditions against those skin problems. So Lindsay's nails, distal brown transverse band. That's Lindsay's nails. I think I have the picture also. This shows kidney disease. Yes. So these are the Lindsay's nail. Says distal brown transverse band. So at the distal, that's it. That's Lindsay's nails, and it shows that there is probability, possibly there is a kidney disease. So maybe we'll quickly look at, or maybe we'll finish with the slides, and then when we go back there, we'll just be looking at the cases. So oncological disease, lumps or nodules, very important. You want to do screening for oncology, you need to understand where lumps or nodules are and how to palpate them and when it is abnormal. So when there is past medical history of cancer or neurological symptoms, so it's a red flag. for oncological disease. So any patient with a past medical history of cancer and they are having neurological symptoms and they have the lumps or nodules abnormal. So lymph node enlargement. So whenever the lymph nodes are enlarged, think of lymphadenopathy. And these are red flags. The moment the lymph nodes are enlarged, refer so that they are going to make sure that it is not cancer. Palpable, fixed, irregular mass in breast, axilla, etc. So it's important for physiotherapists to be able to do assessments for irregular mass in the breast and the axilla, because it's not always that people go to their oncologist or physicians to do those tests, and it's going to help to identify, even if it is a small growth, before it becomes a critical situation. Idiopathic muscle weakness, no cause, just the muscles begin to become weak. Decreased deep tendon reflexes. I think someone, was it Kate, or someone that was mentioning some of this, and I was just thinking of this at that time. Idiopathic muscle weakness. So no cause, there's just muscle weakness. Yes, I think it was Kate that mentioned something similar. Decreased deep tendon reflexes. Early warning signs of cancer. Very important when you see muscle weakness. No reason. No reason. No, you can't explain why. The muscles are getting weak. And you do the tendon reflexes, they are decreased. Unexplained bleeding. So there should be a reason why someone will bleed, but it's unexplained. So it's a red flag. Sign of metastasis with past medical history of cancer. So past medical history of cancer is really a very serious case, in as much as someone has had cancer before. Then any little thing that you see. Earlier we said neurological signs, but here you have signs of metastasis. It's a red flag. Pelvic, groin, SIG, back pain, and sciatica. And there is past medical history of prostate cancer. And the patient has pelvic pain, groin, SIG. This is a red flag for oncological disease. For yellow flags, as much as you are older than 50, begin to look at the signs of cancer. Past medical history of cancer on its own, without any symptom, nothing, just has past medical history of cancer, because in the red flag, you'll see that it's either the past medical history of cancer and neurological conditions, or past medical history of cancer and pain in the back, SIG, or those places that I've mentioned. But if you have just the history, it is a yellow flag. Back, pelvic, groin, hip pain, abdominal complaints, palpable mass, yellow flag. Prolonged / excessive menstrual bleeding. Recent unexplained weight loss of 10% or more of total body weight within 2 weeks to a month. So within a month, someone has lost 10% of their total body weight, unless it can be explained that someone just decided to starve themselves. I had some movie stars that want to feature in some scenes, they want to become very thin, they go through such things, but I don't know if someone can be able to achieve that 10% in just 2 weeks. But if it's possible, that's why it's a yellow flag. So you need to really find out whether it is organic pathology related. And that is why it is just a yellow flag. Any growing mass, just palpate the axilla, wherever it is, and you see a growing mass in a place where there's not supposed to be a growing mass, you have it as a yellow flag. Increase in hematoma. We have seen the picture of hematoma. You see that it continues to become bigger and occupy more space. It's a yellow flag. Signs of nerve root compression. So, I mean, you have nerve root compression, begin to think of other symptoms and signs. Now, neuromuscular red flags for pediatric conditions. Mutiat promised you that will come here. So pediatric conditions, abnormalities of head, macrocephaly, fontanelles, location of face, eyes, and ears. I'm going to post a textbook on how to assess these things. There's a textbook that shows step by step how to assess these abnormalities of head and other assessments that you do in the pediatric conditions. So midline defects of neck and spine, integumentary signs of underlying deformity. When you have abnormal muscle tone, tremors, fasciculations, lack of coordination, unusual movement. So, sorry, I think, let me see if the next slide, because we need to be careful because there are some things, well, yes, these are red flags. Okay, sorry, these are red flags. Because if you have macrocephaly or microcephaly or the fontanelles abnormal, location of the face, the eyes, these are organic pathologies. So yes, we're on the right track. Abnormal muscle tone, tremors, fasciculations, lack of coordination, unusual movements, headaches, seizures, bulbar signs, dysfunction of autonomic nerves. So these are all red flags that will require referral. Abnormal gait or extremity function. So you have ataxia, tremors, hemiplegic gait, or Gower's sign. So usually it might be a progressive, symmetrical, or asymmetrical. Because, you know, for example, in neurological ones we mentioned earlier, if you have Parkinson's disease, it's an organic pathology. If you have a stroke, it's organic pathology. And these are not movement impairments that we treat at the as the cause. So we have pathokinesiological model. So these are pathokinesiological model. The organic pathology sets in, and then you have the movement impairment. And therefore, if you see any of those signs of, because you are looking at neuromuscular, signs that the pathology sets in and there's an gives rise to the movement impairment, then there's definitely need for referral. So fine motor difficulties, early handedness, tremors, poor handwriting, difficulties of feeding, scapular winging. Unusual mental status. This is a very clear case that there is an organic pathology. So lethargy, confusion, amnesia, inappropriate affect or state, a coma, all these are abnormal. They need referral. Arrested, deteriorating, or abnormal motor development. Sensory changes, numbness, paresthesia, hemiplegia, neglect of one side. Dizziness, fainting, onset of falling, inability to stand. So fainting on its own is a red flag, even in adults, not to talk of children. Hypo or hypertension, abnormal sweating, irregular respirations, called the Cushing triad. Cerebrospinal fluid leak from ears or nose, directly refer. Signs of increased intracranial pressure. I think we have dealt with this in that of the adult is the same thing as for the children. Primitive reflexes. So when you have the delayed developmental milestones. So for the cardiopulmonary red flags, poor feeding, poor weight gain, the murmurs, cyanosis, rhinorrhea, fever, abnormal heart rate, abnormal heart sounds. And for those in pediatrics, you know how to do the assessments. And as I've said, knowing what to see is one thing. Being able to identify that is another thing. So how do you know that there is abnormal heart rate in a child? How do you know that abnormal heart sounds in a child? Signs of respiratory distress. There are some of those assessments that are different from the way they are done in adults. So very important to be able to, if you are practicing in pediatrics, to be able to know the procedures, how to identify those things. I think someone asked me a question yesterday that I didn't answer. The person, I don't know whether it's Joshua Imoro or someone, that said, how are these things in pediatrics? I skipped it and I later went back. So the principles, as I explained yesterday, are the same, that you must be able to identify if there is an organic pathology. But the procedure of identifying the risk factors, symptoms, and signs may be different from pediatrics to adults. Very, very important. In fact, the outcome measures usually differ between what we give as an outcome measure for that of adults and that of pediatrics. So chest pain, unusual tiredness, dizziness, and you'll see that in adults, sometimes you have a combination of risk factors, symptoms, and signs before you form a red flag. But in pediatrics, you don't, even one symptom that you see in adults that you need other symptoms and risk factors to form a red flag. In pediatrics, it can be a red flag. So these are all things that you can see in a child and begin to suspect that there may be an organic pathology. So this is the end of the slides. Let me share the book very quickly. I will not go beyond 4. So very quickly, I'm going to go through the book. So first of all, let's see if there is any yes. Musculoskeletal, endocrine. I think we have looked at endocrine. Neurological system, we have not looked at neurological, but that's what we did on Saturday and yesterday. But I think that of neurological should be simple because we're looking at headaches, memory problems, fainting, trouble seeing or hearing, dizziness. I think they are directly the way they are in the books because people understand those terminologies. We also have the elderly patient, different questions that you ask. It is there in the book, but they are not in my slides. So very important, current treatment and drugs. You can see that past history. You can see a lot of clacking explanations about how to clack the patients for the purpose of getting to that point that you make a physical diagnosis. This book is available on the WhatsApp platform. We have looked at cancer. Let's see if we can have at least one case report on cancer. Okay, cancer reoccurrence. So I don't know if there's another person that can help read for us. Let me see if there are hands. Oh, wait a minute. Have I shared? Okay, I don't think.
No.
Oh, I've not shared. Oh, all this while I thought I've shared. I'm sorry. Okay, I thought I've shared. Okay, is it shared now?
Yes.
Okay, so please, can someone help read out this case example or risk factors for cancer recurrence?
A 46-year-old woman presented with mid-thoracic back pain, which she has had for the past 2 weeks. To describe the pain as sharp and rated it as 7 on the numeric rating scale. The pain was increased when she raised her arms off her head and relieved when she put her arm down. There were no other aggravating or relieving factors. The client also noted occasional shoulder pain, sometimes with back pain and sometimes by itself. There were no other reported symptoms of any kind. Past medical history included breast cancer diagnosed and treated 8 years ago with no cancer reoccurrence. The client had 7 nodes removed. 12 were positive and a mastectomy followed by chemotherapy short-term and tamoxifen long-term. The client was estrogen negative. The clinical presentation was consistent with a posterior rib dysfunction, but there was no identified trauma of cause attributed to the onset of the back pain. The therapist's judgment was that there were enough risk factors in the history for cancer reoccurrence combined with additional red flags, e.g., age over 40 years, pain level, insidious onset, to warrant medical evaluation before a plan of care was established.
So thank you very much. Before we look at the results, can we identify the red flags? What are the red flags in this case? If there are red flags? You want me to push back? I know we are all tired.
Breast cancer.
Okay.
Diagnosed and treated 8 years ago.
Okay, yes. So that's, I think, we said yellow flag. The moment there is past medical history, yellow flag has been established. But what other things are there that when you link it to them, that you have a red flag? What do we have there? Are there any neurological signs? I have not seen neurological signs. What other things did we have? I also noted occasional shoulder pain. So we have pain in some parts of the body, sometimes with back pain. Remember, there was one of the red flags that was said, if there is past medical history and there is back pain, groin pain, or some other pains in the body, that it is a red flag. So at least we have a red flag. So can we just quickly read the results?
Okay. Results. Claire was diagnosed with cancer metastasis to the thoracic vertebra at T4 to T6. The physician called the therapist to ask what tipped her off to the need for medical referral. Knowing the risk factors for cancer and for cancer recurrence made a difference in this case.
Exactly. Yes. So if our edit has also posted that past medical history of breast cancer and then mid-back pain. Yes, true. So all those two put together formed a red flag. And that helped with referral to the physician, and they were able to identify a recurrence. That is wonderful. That is good. I think possibly we are going to stop here. Let me just quickly scroll and see what condition we have next. So palpable and observable lymph node. This is another case report. We have cancer-related skin rash. I think we have seen all this. So these are just examples. Can you see pictures that are showing the skin rashes and some of the other skin problems that were mentioned earlier in the slides? So this is really a very good book for us to be able to understand all this as arthritis associated with carcinoma, uterine cancer with bone metastasis. A lot, really, a lot. If you want to understand systems review, I think I really study this book very well. There might be another version after this. If I get that, I will send it to you. But if not, this is really also good to study. Screening the head and neck. Okay, I thought maybe I will come across that of pediatrics so that we can take at least one case report. But if you go through the book, you'll find where pediatrics is, because I'm very sure it's there. So thank you so much, everyone. I think I can imagine how the assimilation will be starting from 9. Wow, I forgot that we even started 9. We would have stopped exactly by 3. But thank you so much for still showing commitment all through with the responses, those that were reading out. Thank you so much, everyone. Any questions or comments before we conclude? Okay, you said I would love to share item 7. Please go ahead. Go ahead. Explain to us how you want to share that item 7. Thank you.
Thank you, sir.
Okay. So I just want to see if it's a question. I think they're all appreciations. I thank you to all. Okay. Okay. So, I can see a hand. Olofin, Temilade Maria, right? Please go ahead, unmute and speak.
Yes. Thank you very much, sir. It was a very wonderful presentation. I really enjoyed it. With my little years of experience, I just wanted to confirm something. So I've seen a case of a 8-year-old boy who presented to the clinic for infertile hemiplegia. So the reason why the mother just came on first contact basis was for the residual weakness. And I saw in the presentation where under the neuromuscular red flag, that we should refer. So I wanted to know that type of condition, do we still need to refer, or we can just go ahead and undo the residual weakness? Cognition was intact, every other thing. Well, the reason why the mother presented was because they started using the deformity the child had on the hand to start making jest of him in school. So that was why they came to physiotherapy. So I wanted to know, do we still need to refer that type of case, or we can just keep?
Actually, the reason for referral is if there is a suspicion of an organic pathology. Now, in this particular case, if you have any reason to believe that the weakness that you have is as a result of a movement-related impairment, there is no need to refer, even in pediatrics. The reason why you have just one symptom or sign makes you to refer is because identifying organic pathology in children is more difficult. If you look at all those signs and symptoms in adults, usually there are signs that you ask them. Do you have lightheadedness? Have you fainted? Do you have what happens to the pain in your shoulder if you change position, if you do this, if you do that? I find that it's very easy to get all those answers. And you now build up a case in your evaluation to say that this should be referred. But in a child, it's difficult to get all those answers. And that is why even with one that shows that there may be a possibility of an organic pathology, you refer, so that the assessment that would be done possibly might not be to look at symptoms that come from responses from the child. It might be investigations that are going to help. And that is one of the reasons why you see those just symptoms, one symptom that are required for referral. But if you have a muscle weakness and you know the cause, maybe the child fell, and because the child fell, he became afraid to now be moving. There is no fracture. There is nothing that shows that there should be an organic pathology. You understand very well from the history said about the child that this is just something that if you strengthen, it is going to become strong and the patient is going to continue to walk and move around. There is no need to refer. But if you can't be able to get a cause, and this must have a cause, is that cause from movement impairment or is it from organic pathology? And you don't want to just assume and say, okay, let me just be treating. It's possible there is an underlying organic pathology. That is why the need for referral will come. But I think it's important to reach out to experts in pediatric physiotherapy to be able to get much more specific responses to the question. Thank you. Chijioke or Tifa. Yes.
Thank you very much, sir. The question is,
I don't think we can hear you well.
No. Can you hear me, sir?
Yeah, we can hear now. Andrea, we couldn't hear, but I think I can hear you now.
Okay. So the question is from a pregnant woman, 28 weeks pregnant. And she asked that, okay, this is what she sent. Please, I'm 28 weeks gone. And for 4 days now, I've been having one kind of pain at my upper backbone towards the neck side, not the lower part. It feels as if something heavy was placed there to the extent that I can't swallow properly. If I do, it will be as if what I swallowed is hitting me at that bone. If I use pain relief, it would subside for a while. Later, the pain will come back again. Even if I try to swallow saliva, once it gets to the upper backbone region, the bone will pain me, like in her own words. Now I'm scared to swallow anything. Please, what could be the problem, or is it normal? And then when I asked further questions, I sent her a picture of a bareback and asked her to, to circle the region she was feeling the pain. It was basically between the two scapular bones. So just that middle point, that was what she circled. So I was wondering what could be the approach, the right approach to this in terms of referring to a professional who is the right person to refer to. Should it be her obgyn or should it be maybe a gastroenterologist. So that's why I decided to bring up the question.
Okay, thank you very much. From what you have just stated, I see yellow flags, not red flag yet. So I think we need to ask more questions. If you have difficulty swallowing, but it's pain, not that you're having difficulty swallowing it, but when you swallow, there is pain. So at least we have something that is coming from the GIT. But we also have something coming from the musculoskeletal. But what we don't know is that musculoskeletal, is it really musculoskeletal or is it something referred? Because remember, we talked about when you eat, you have relief of pain in musculoskeletal problems. So now when you are swallowing, you're now having pain in the musculoskeletal. So it's possible that it is from the organs that when you are trying to swallow or when you are trying to eat, that pain is referred. So now you go to the musculoskeletal area and you do your assessments. So the palpation, the movement, and other special tests. Do they reproduce pain? So that's the first thing. So is there a musculoskeletal problem? Is there now the history? What really caused the pain that they have musculoskeletally? Can you link it to any cause that is of musculoskeletal in origin? So there are a number of questions that need to be asked. From what you have right now is a yellow flag, but you now have at least GIT, you have musculoskeletal, and you can have others because the issue of problem swallowing is not just in GIT. If you go back to what we have done, you'll see that it can reflect in another system. You now pick those systems and you now assess them more. And that will give you an indication of whether there are enough symptoms put together to have a red flag for organic pathology. So right now, with this alone, we don't know whether it is movement dysfunction or organic pathology. You need to do more assessments. And it is all these things that we have done that you're going to look at, continue to ask questions, do the test. And believe me, this is what professionalism is all about. To say, I am a professional. This is what it's all about. You do the assessment, but most important thing, use clinical reasoning to do the evaluation so that at the end of the day, you come up with the decision. This is movement dysfunction, and this is the exact physical diagnosis, and this is what I'm going to treat. This is not, it is a case of referral because I can see signs of organic pathology that require referral. But most importantly, what are the questions that you ask? What are the tests that you do? And when they come, what should be your evaluation? So it's a lot of work. That alone cannot give us an answer. You need to go and probe and ask more questions. I think I saw a question here that said, I would love if there would be a standalone course on identification of red and yellow flags. We can have that. We can have that. Hafiz, please just take note of this. Let's discuss so that we'll see how we can come up with something. So we are not going to go into all these details. We'll only focus on red flags and yellow flags in patients across the specializations. So thank you so much, everyone. I can't see any hands or any questions on the chat forum. Thank you so much. Still, I will emphasize that I was happy when I had some people really going back to the clinic with those new things to put them in practice. When we come to do that workshop that Josefa is asking for, we will ask for testimonies, how you have used these new things. What have you found? What cases were you able to discover? Your relationship with the physicians and others and all that. So thank you so much. Please, let's go back and begin to put them in practice in the clinics. Bye-bye, everyone. Thank you.
Drama. Have you finished your carrot?